All right, good afternoon, everybody. Welcome to Rounds on the third Friday. Our pleasure to our featured speaker today is Dr. Raymond Cho, who's professor, Department of Ophthalmology, Visual Sciences, Director of Oculoplastic and Orbital Surgery at the Ohio State University, Wexner Medical School. And he'll be presenting a talk called The Faces of Ukraine. I'll present a formal introduction of him prior to his lecture. For Zoom meeting attendees, please mute yourself, and for technical issues, please enter help in the Zoom chat. Everybody knows where that is by now. Claiming CME, look for an email on Monday or Tuesday, complete the survey, and then this should be posted to credit on May 1st, 2020. The activity is approved for MAPRA Category 1 credit only, applicable to physicians, New York State and Pennsylvania optometrists, and may apply to some nurses and ophthalmic technicians. If you have questions about accreditation, please email Stephen_Coffrin@urmc.rochester.edu. Disclosures for today for Doctors Leckenby and Doctors Cho. I'll let you read those. Just give you a minute to go over that. Disclosures, accreditation, the University of Rochester School of Medicine and Dentistry is accredited by the Accreditation Council for continuing medical education to provide continuing medical education for physicians. The University of Rochester School of Medicine and Dentistry designates this live activity for a maximum of 3.0 credits, and you should only claim the credit commensurate with your participation. Here's the financial relationships. Dr. Leckenby, scientific advisor for Slaxa, no other disclosures. The rough itinerary, Dr. Leckenby will present first, about 25-minute talk and some questions for discussion, and then we'll present three plastics cases by the residents, followed by the featured lecture. So it's my pleasure to introduce Dr. Jonathan Leckenby today, Assistant Professor of Surgery here at our own University of Rochester School of Medicine. He'll be presenting functional muscle transfer to restore blank and facial palsy patients. He attended medical school in London and completed his plastic surgery residency at the Royal Free Hospital, University of London. During his residency, he became interested in treating facial paralysis and spent 2 years at Harvard in Jeff Lichtman's lab researching peripheral nerve regeneration. He went on to be awarded his PhD from the University of London in 2019. Dr. Leckenby completed an academic fellowship at the University of Bern, Switzerland, and a microsurgery fellowship in London. He moved to Rochester in 2018 and has built a basic science research lab that focuses on the peripheral nervous system and was awarded his first NIH research grant in 2022. Congratulations, that's great. Dr. Leckenby's clinical practice is centered on treating facial and peripheral nerve injuries and performing complex microsurgical reconstruction. He has a joint appointment in the Great Ormond Street Hospital for Sick Children in London, where his practice is entirely focused on treating congenital and acquired facial palsy in children. Please welcome Dr. Leckenby for the Spotlight Lecture.
Well, take two. Thank you very much for having me to present. So my sort of passion is treating facial paralysis. Now, this has been around for a long time. The first functional muscle transfer to restore smile was done back in '76 by Hari from the Japanese group. And really, there are nuances to it, but really the outcomes haven't changed much. And that was what my research was based on. I was trying to sort of see if we can get external regeneration to improve. But I want to show you, which is more relevant to this group or this audience, is what we're doing to reanimate the eye. So as I said, historically, Gillies was the first guy to really start doing these sort of muscle transfers. He did a temporalis transfers for the eye, which sort of gave a lot of bulk, as you can imagine, to come to the lateral orbital rim, and it was not a very aesthetically pleasing result, and you had to sort of work on biting to really stimulate the eye closure. You had the palpable spring, which has been around for a while, but it's fell out of sort of favor because they would fracture or they would extrude. Nassif, a Brazilian gentleman in Sao Paulo, he has been using free neurotized platysma grafts. So he basically does blepharoplasty incisions and inserts a bit of muscle from the platysma and throws on a nerve, and it should regenerate into there. And then really the pioneer of the functional muscle transfer was Gulinks, who described it actually quite a long time ago, so in 2010, but never wrote it up until 2018. So this is the technique that we've been modified and we've been sort of implementing since 2011. And this is sort of our initial series. So we wanted to really know is this a good operation, essentially? Do we get good results? And most of these are in kids. And the idea is, actually, how do they sort of grow up with this long term? And can we actually restore the blink reflex in these patients? So we started out with a cadaveric study. We went up to the lab and found 18 cadavers and dissected them to look at really what the platysma muscle is, the size, whatever. And typically it was 12 centimeters, which is kind of the important thing. Obviously, kids, you have slight a change in the proportions of the anatomy of the size of the head. So again, we sort of try and let them become a bit more skeletally mature when we start intervening to around 10, because the muscle's obviously a little bit smaller. We wanted to know what the nerve supply is, and there's some arguments about this, and whether we should be taking marginal mandibular branch, whether it's a cervical branch, which comes off slightly lower. We choose to take always the marginal mandibular because, yes, you have a bit of fallout and weakness of the depressor, but they're paralyzing the other side, and a lot of the facial reanimation procedures we do to the other side to enhance the smile, we don't really address the depressor. So actually, typically, if we weren't sort of taking the platysma, we would have to give them Botox on the functioning side to symmetrize them anyway with the vectors of force. So losing a little bit of power in the depressor is not a terrible thing from the facial paralysis standpoint. So we routinely take a marginal mandibular branch, not the main one, and I'll show you how we do that. And that's really what the cadaveric muscle looks like. I'll show you when we've harvested it, what it looks like in vivo. We wanted to make sure we were doing the right thing with the blood supply, so we looked at a bunch of CT angiograms, because the blood supply to the platysma is basically a perforator off typically the submental artery. Now, the submental artery is really pretty short and it's hard to use. You don't want to see the perforator, as I'll show you, when you're actually raising this flap. And what we actually end up doing is taking the facial vein and facial artery right up into the face and using it reverse flow. So we're actually perfusing it the other way because you get a lot more length, and it's useful when you're trying to hook it up to the superficial temporals, which I'll show you in a minute. So we really want to make sure that we had a reliable supply that we could use the facial artery for. And so we managed to conclude that it's safe to do this. So our approach is typically two-stage operation. So the first stage, we normally wouldn't consider operating on kids until they're at least 4 years old, because the length of the sural nerve, which we harvest endoscopically, is limited to get from one side of the face to the other. At 4 years old, in this case, we typically would combine this with a facial procedure as well, so to reanimate the smile. So we have to take two sural nerve harvests. We like to take the sural nerve because it's the longest one we can really get. And so we open the good side of the face to find a functioning, so the functioning side of the face, to find a very distal buccal branch just outside of the parotid region. And then also you then stimulate to find a zygomatic branch as well. So you pass these cross-facial nerve grafts to the contralateral side, do the neuropathy to hook them up to the non-paralyzed face, and then you leave them for 6 to 12 months to regenerate across that. You can monitor this in kids. It's difficult with the Tinel science. You tap where you join here and hopefully they can have sort of some sensation as to give you an idea of where it goes. But it's slightly dumbfounding because the facial nerve is predominantly a motor nerve. So why you get a sensory sort of response to it, we don't know. But still, it's a loose. Surgeons like to do it just to reassure themselves. So we put, obviously now having two, you don't want to hook the wrong one up to the wrong one. So for the eye, we use Proline, and for the face, for the buccal branch, we use nylon. So we've got a blue stitch and a black stitch. So we can differentiate between the two. So this is a video of us raising the flap, and I'll talk you through it as we go. I'll make sure we're mute. So we use a modified facelift incision from the non-paralyzed side. So we've already gone through the side anyway to find the nerve, the buccal branch, and the zygomatic branch, the facial nerve to use. So we just extend the incision slightly. We Now, so the border, so the landmarks we're looking for is sternocleidomastoid. We follow that all the way down. So that's the posterior border. We go to the midline, and then we go right down to the clavicle. And the first thing, important thing is to dissect the anterior surface of the flap. So marking the angle of the mandible, and a centimeter below there, you will find the marginal mandibular branch. So we go in, you can see it here, we're stimulating, and I'll show you, hopefully you'll see the corner of the mouth twitching on some of them, and just the platysma twitching on some of the other ones. Here we go. So hopefully you're looking, so here you'll see just a twitch in the, up here, and then also then you'll see the muscle twitching down here as well. Yeah. So we confirm that we've got a good a good nerve supply to the platysma. It's a really thin muscle. And for those in the room who have seen neck dissections, etc., the skin flap, we're always somewhat concerned about because that's what you always told us to take the platysma with your skin flap when you're doing a neck dissection to keep it vascularized. It doesn't seem that that's a problem, certainly in kids. And here you can now see, once we've detached it from the clavicle, we're reflecting it up anteriorly or cranially. And then you can see that perforator underneath. Pedicle coming here, and this is the flap completely raised from the body, and then here we are. Oh, sorry, that was a bit fast. I'll go back to this bit because we always like to perfuse to make sure that I think it cuts off right at the end, but you can see there's a drop of blood coming out of here, so you know it is congruent. So the flap is going to survive if it's connected up, all right. And so then the next, this is this is the next video. This is the inside of the flap, so you can see. We tunnel it pretarsally from one side, make an incision over the medial canthus, pass it through the tunnels, secure it with just Vicryl, Vicryl, and it seems to hold pretty nicely because it's not going to move for a while. We hook up to the superficial temporal artery and vein to give perfusion, and then you've got the cross-facial nerve graft at the top here to provide a nerve supply to the flap. So these are our outcomes. So we looked at, we did, I think it was 23 in between 2011 to 2018. We've now done more than 35, and it was a 2-year follow-up. We like to use something called eFace. It was developed by the Mass Ear and Eye, Tessa Hadlock. It's sort of a crude, you just have a slider and say what's complete, incomplete, closure, or smile, is it how asymmetrical it is, but it's widely popular now. Fortunately, in facial palsy outcomes assessment. So we looked at the resting palpable fissure, gentle eye closure, and forced eye closure. There were 26, sorry, we're now about 35. The average age was 10, because I think we wanted to start this in slightly older kids as well, just to sort of give us the best chance for the anatomy. We didn't have any flap failures and no revisions for the eye. One of the cheeks was slightly bulky due to the, we use a pectoralis minor flap for the cheek and the smile. And we didn't have any major outcomes, sort of complications. So you can see the blink reflex we tested on everyone preoperatively. No one had a blink reflex on their paralyzed side, unsurprisingly, because they couldn't move the oculi rather, sorry. Afterwards, we managed to get this back in 22 out of 23 patients, which is kind of big deal. Epiphora also improved drastically, went down. 18 patients had this before. That was our principal complaint, and that dropped down to 3. Now you can see, so when you're looking at palpable fissure, 100 should be the ideal score. So you can see in pre-op they had sort of a bit lower. Post-op, we've actually lowered this down, and that's a sign of ptosis a little bit from the upper lid, which you'll see in the post-op pictures I'll show you now. But you can see gentle closure, we didn't actually make much of a difference to. But in forced closure, when we asked them to really scrunch their eyes up, they definitely improved considerably, almost 89, not 100%, but still going from 45, which is half the ability to close your eye, to almost completely close the eye. And those are just the significant. So this is a pre-op kid. He's got hemifacial microsomia on both sides. And post-op, you can see, so this is pre-op. You can see he's really can't close, his left eye doesn't close that well, but his right eye is definitely left open, and he had recurrent conjunctivitis and infections. See, post-op now, when he's really trying to close his eye, he can actually close his right eye completely now. So this is 26 months post-op. This guy with Goldenhar syndrome, you can see he's still, so when he's gently closing his eye, he really doesn't get much closure here, but when he's really trying to force it closed, he does have a bit more closure, but post-op, he's now completely closed. Critically, we are getting a bit of ptosis on this side, which we're not too happy about, but it doesn't bother him at all. And you can see the scars, the medial canthal incision is very well tolerated, it heals nicely. And the third case, again, he really had a lot of scleral show. And then afterwards, still got some weak closure. His scar is not ideal if we're critical, but when he closes his eyes forcefully, he's almost completely closed. This is the last case that I have. I'll show you a video of this guy. He was actually the first one we did in 2011. And this is post-op 18 months, and this is now at 4 years. So again, critically, he does have ptosis on the right, which is obviously the side we did, but he now has complete eye closure and he doesn't have any recurrent infections, which is great. And this is a video of him to sort of show the blink. So he can't wink, but he can always blink, if that makes sense. So you can see it's also spontaneous at the very end where he flutters his eyes. So that's gentle closure. This is forced closure, and now he's blinking on both sides. So that is the results we do get, and it keeps our eye well lubricated. So just to discuss and open it to a discussion. We can get excellent eye closure following this procedure. It's it's a very complex procedure. The second operation will take 10 hours, 12 hours in surgery because we typically combine it, as I said, with a second free flap as well. We haven't had a problem with bulkiness. That was always a concern that we have, but we do have slight ptosis. But actually, when you ask the patients, that doesn't bother them, which is great. This is a sheet of muscle. It's not a sphincter of any sort. So we're sort of trying to ask it to do a job it's not designed to do. And it's still not quite natural. And I think that's why when you ask for gentle eye closure, you don't get it completely. Because it's just basically closing a slit in the eye rather than actually a sphincter. But it does protect the globe. 96% have had restoration well, only one patient didn't have a blink reflex out of this series. And it keeps the actual conjunctiva healthy. So patient selection, this is the hardest part, I think, that we're still trying to learn, even though we've been doing it now for almost 14, 15 years. Who should we do this procedure to? And I think our sort of rule of thumb is having recurrent episodes of conjunctivitis, so requiring antibiotics. They need that 2 or 3 times a year. The epiphoria has really got to bother them. And the lack of a Bell's phenomenal reflex, which is the upturning of the eyeball when you have facial paralysis. So those are the 3 criteria. We're actually becoming less stringent with that. We're actually opening it up to more people because we're seeing great results with it. So we will offer it to patients who really struggle with their eye closure a little bit, who don't have recurrent infections. And I think as we have been doing this for so long, we haven't seen any of the major long-term complications of sort of, oh, this is now too tight. Or when you're doing functional muscle transfers, one of the things you can get is over tightness because you're using a skeletal muscle essentially, which is not meant to be tonically active. So we haven't had that in the eye in comparison to the cheek, for example, but it is a very thin muscle. So in conclusion, we think this is a great option for some patients. And what's really great is it does manage to restore the blink reflex. Obviously, as I said, you can't wink, you can only blink. But open for discussion. Any questions?
Thank you so much for presenting. This is very exciting. It's a very common problem. So it's great to have new tools available to address it. I'm curious about what is the typical mass of the graft?
So it's about 2 grams. We typically actually when we're doing the facial reanimation part, we try and get the muscle down to about 9, depending on obviously the age of the kids, but in a young kid, so age, probably we try and get these completed by the time they're 8, because that's when children become aware that they are disfigured and other people have a different perception to them. So we try and get them around 6 to 8 years for the second stage, or certainly complete their treatment. And the muscle we use for the cheek for that is under 12 grams. We aim for about 9 to 12 grams. And the eye, as I said, 2 to 3. It's very small. That's why I think there's a bit of an argument like, why do you go to all this complexity? Why are you hooking up the vascular supply? And as Nasir, the guy from Sao Paulo, the Brazilian, although he hasn't demonstrated that they revascularize as a graft, but we are seeing in other areas of plastic surgery and sort of nerve surgery, so-called RP&I, which are regional peripheral nerve interface. Basically, this is people who have either amputations or looking for wrist transplants. The guy in Michigan, Paul Sedona, has pioneered this treatment where you find a nerve, you wrap it in a small cuff of muscle and bank it under the skin, and that survives. So much. The reason why is then you can pick up a signal. So if you just bury the nerve under your skin, there's too much noise and it's not a powerful enough signal. If you put a muscle on there that contracts in response to the nerve being activated, you can pick up transducers transcutaneously. So when you come to things like prostheses, you can have 7 degrees of freedom rather than going through the complex hand transplantation, face transplantation sort of thing. So I haven't done any grafts because this is the way I was taught, and I've seen the outcomes of these and they're great. But it would be interesting to sort of compare and look at some sort of vascular anatomy and look at that. But we're, as a community, not very good at sort of being collaborative and sharing our results with other people and making sure that we are doing the right thing.
Thank you again. Fascinating talk. Have you considered doing this in adults?
Yeah. So the oldest patient we've done it is 35. And I mean, this is an ongoing, because I mean, adults tend to have more of a problem with their eye than kids in facial paralysis, because obviously their skin laxity goes over time. And one thing that I've been trying to push, certainly my mentors who've done 700 facial sort of reanimation procedures, is to look at what are the long-term benefits of, if you restore the cheek with a muscle, do you support the lower lid? And so therefore, do you sort of minimize the eye complications later on in life? The response I got was, no, we don't want to phone our patients because they'll have complaints and they'll want to have revisions and things like that, which wasn't very helpful. But I think going forward, that's something that I'm keeping a track of. And certainly, I mean, that kid, the 4-year-old, he was 4-year-old that's post-op film. He's now, we last saw him last summer. I should have got a video, but he looks great. And his eye is not problematic. He's great. So I don't see there is, traditionally people will avoid doing a 2-stage procedure. So with a long cross-facial nerve graft, because you get older, your axonal regeneration ability diminishes. I think that was a very historical mindset. And now I think we're pushing the boundaries a little bit more. And I'm seeing, I mean, certainly the guys in Michigan are doing cross-facial nerve grafts on 7-year-olds and they're getting some response. But it's just, that's a long shot. I mean, someone who wants a quick benefit isn't going to want that procedure, because it's going to be 4 years before you actually get your end result. But yeah, so I think in sort of adolescence and sort of 30s to 40s, I think this is a viable procedure. And anatomically, it would be a much easier dissection as well, less stressful.
Good. Okay. I'm going to present a case called a singular presentation of cicatricial ectropion. So this is a 33-year-old male who presented to the oculoplastic service in May of last year. And was referred by our ENT colleagues for ectropion in the setting of plaid, which we will talk extensively about in the next few slides, with diffuse facial scarring, all over the body actually. History of multiple resected skin cancers and status post pal excision and closure 9 months prior with some facial reconstruction. Medical history is this plaid syndrome, notable also for multiple facial squamous lesion, status post resection with ENT and others, status post a bone marrow transplant in 2019, hypogammaglobulinemia, asthma and inflammatory arthritis. And patient reports in terms of ophthalmologic history that the lids have been like this for about 6 years. We'll see a picture shortly with occasional tearing and crusting. Vision is fine in both eyes. This is the exam from that initial consultation with facial plastics. We can see lower lid cicatricial ectropion bilaterally with accompanying signs that we might expect to see some injection and signs of dryness. So these photos are actually from before ENT did their reconstructive procedures and lesion excision procedures. So we can kind of see a typical skin lesion on the right-hand side that dramatic atropine on the left-hand side. You'll also note, kind of in addition to the generally scarred over quality of the skin, that the nasal cartilage, and actually some of the auricular cartilage was missing as well. So, what is PLAD? It's not a very good acronym, I don't think, because it stands for PLCG2, associated antibody deficiency immune dysregulation. Kind of been a more recent interest in it, early mentioned in New England Journal paper from 2012. Extremely rare. About 50 known cases as of 2015 in a paper that I was believe written actually by this particular patient's clinician following this condition. It's caused by mutation in the phospholipase C gamma 2 gene, usually a deletion, with autosomal dominant transmission. And it's generally thought to be lead to a malfunction in the IP3 DAG pathway, which you guys may recall from medical school, kind of a general phosphorylative pathway. Explainable in this case, as we know from Dr. Levin in genetics, that there's variable expression in different cell lines and different organ systems, and this tends to affect particularly myeloid and lymphoid lines. So heterogeneous presentation, but features in different patients may include an urticarial reaction to evaporative cooling. Particularly curious because they will do like an ice cube test, and if you put like ice on someone, something on one of these patients, something very cold, they won't have urticaria, but it's actually if they get out of a pool or out of a shower and the water is evaporating, that they get this reaction. We don't know why that is. A granulomatous dermatitis, an acral predilection makes sense with it's inclined to be associated with colder environments and colder areas of the body as opposed to warmer. Recurrent infections, development of autoantibodies, IBD, ILD, and inflammatory arthritis. The particular phenotype that we see that present among those different features may have to do with the gain of function versus loss of function. That's kind of the latest in terms of the research on this condition. It's pretty rare to have malignancies and then this cartilaginous destruction that we see in this case. There was a paper that just came out this year actually that looked at a number of mutations in this gene, variants of unknown significance. You can see there's basically an order of magnitude greater quote unquote typical associations, these recurrent infections and autoinflammation as opposed to malignancies. Management such as it is tends to be trigger avoidance. So they've talked about toweling off immediately after showering, same thing after exercise or trying maybe to avoid exerting yourself to the point of sweating. And if so, again, drying yourself off rapidly. Also discussion about IV prophylactic measures like IVIG, prophylactic antibiotics for those prone to recurrent infection. Very interestingly, as I was going through this case, if you look for stem cell transplant and variations thereof in this condition, there's actually not much mentioned in the literature. If you go to PubMed and you put PLAD stem cell transplant or bone marrow transplant, there's actually no hits. But nonetheless, in this patient, this was done again with the thinking that if this primarily affects, it tends to affect the B cells and NK cells, sparing T cells. But if we can sort of replenish those lines or replace those lines with healthy cell lines, then maybe we won't have these phenotypic manifestations. And it seems to be going well per the allergist's most recent note. So just getting back to our particular patient, it's interesting because again, we have this very rare condition, but it's even a rare, possibly even singular in some ways, presentation of a rare condition. Just wanted to pull a few quotes from this allergist's note who'd been following the patient for a long time. This is a little bit before the patient saw oculoplastics, characterized it as the most severe granulomatous dermatitis of any plaid patient, presumably of whom I'm aware, starting from birth and progressing to a large percentage of his body surface area and loss of ear and nose cartilage. So that's in this rare condition, even that's pretty atypical. Consistent with autosomal dominant transmission, does have multiple family members with plaid, but none are as severe as this patient's manifestation. The patient historically has had a characteristic cold urticaria as well as B cell deficiency, recurrent infection, IgE elevation, and inflammatory arthritis. About 2017 started the squamous cell carcinomas, in fact, were noted. So 6-7 years ago or so. And then, as we mentioned, in 2019, had that stem cell transplant. This physician noted that the development of the SCCs has slowed down. I also highlighted from this note that at the time of this evaluation, there were no evaporative cooling induced hives. It seems from the note that there were before this characteristic cold urticaria. So what this tells us, getting kind of back into the oculoplastics, in terms of planning the procedure, is that we want to make sure, obviously, that there's no, or that an inflammatory condition, just like you don't want to operate in an eye that, you know, is a hot eye that has uveitis. You want to wait for it to kind of to cool down, as it were. Similar principle driving planning of this procedure. So getting back to our initial consultation. So the plan was made for surgical repair of the ectropion with referral to ocular genetics, who saw the patient a couple months later. They did not have access to the genetic testing report. I don't know if they do at this time today, I mean, but agreed with a plan for the ectropion repair. And then the next couple months and a couple visits were focused on basically repeating the skin test alluded to in the allergist's note. And again, with this key realization that if you were to operate on skin, on tissue that's actively either actively auto-inflamed or predisposed to auto-inflammation, then you know, are you going to end up with just kind of with more scarring, more cicatrization, even though that's the condition you're trying to treat. So that test was negative. And so I'm going to show a video here. This is from Richard Allen at Iowa, and it's obviously not our patient, but I will kind of narrate it as it was in the operative note, which is fairly similar, but I'll note a few different variations here. So we see a subciliary incision here, and Dr. Gonzalez ended up releasing, kind of phase one was releasing the cicatricial tissue, which extend to the septum and the lower lid retractors, achieving better mobility, as we see in this particular case. Second is kind of the structural reconstruction. So a canthotomy, cantholysis being performed here. In our case, actually 4 millimeters of tissue was excised as well at this point. And here we see a lateral tarsal strips, separation of the anterior from posterior lamellae, and then the tarsus is going to be sutured to the lateral canthal tendon at the level of Whitnall's tubercle. And then we enter what we might call stage 3. We're left with about a 2 by 4 centimeter defect. This is showing basically a talfa gauze, which makes a nice graft template. In this video, they end up using a post-auricular graft. which you will see shortly. In our patient, it was a supraclavicular graft. Just worth noting that, you know, sometimes you'll harvest tissue from areas that have a lot of subcutaneous tissue, subcutaneous fat, and in this case, you're wanting to clear some of that out so that you're left with dermis and epidermis. So the patient really had a very good post-operative course. Now, one eye was done and then the other, there was consideration of the patient possibly needing a temporary tarsorrhaphy. And so that was one consideration behind the unilateral approach, but also, again, we didn't know how this how the tissue was going to react after having had surgery. So kind of doing the procedure in a stepwise fashion. So December 1st was the first eye, the left eye, and then about a month later did the second eye, and really kind of achieved a lot of what we'd hoped to achieve. Lid closure, better lid closure, and lid mobility, better, more natural position in protecting that ocular surface. There was a little bit of concern for maybe a little bit of suspicious drainage and a graft dehiscence at one point, but put on some antibiotics and nothing of great concern. So generally a very successful course. So just a few questions, some for our guest here and then also for the room. We talked a little bit about modifications and the principles, the thinking that goes into what we do differently from a typical cicatricial ectropion repair testing to try to ensure as well as we can that there isn't any active inflammation. Dr. Gonzalez also had the patient warmed up intraoperatively. Again, given that the predilection for autoinflammation in colder settings, so taking that additional precautions. So are there other modifications to a typical cicatricial ectropion repair that you might have pursued in this case, if there is indeed a typical cicatricial ectropion repair? How might we have approached this case if after the procedure that the cicatricial tissue started reforming in a similar fashion, or if if the patient maybe hadn't had a successful stem cell transplant and we didn't quite know how to control the inflammation, how might we approach this case in that setting? More broader question for anybody who's come across singular, perhaps unique cases where there isn't great literature on a condition, or maybe there isn't even a case report. How, as physicians, do we approach these cases? Again, be interested to hear different people's experiences. And I don't know if there are any geneticists here. So we maybe.
I'm here. I'm not in the room, but I just want to make two comments. One is, this is a great example of a shift that's happened over the last, 2 decades. Plaid is an unfortunate name, right? Just like Mongolism is an unfortunate name. Catch-22 was the name for 22q11, Midas syndrome. We've tried to get rid of those names in genetics. And I would say what's settled on for this syndrome itself is really to call it the PLGC2 related disorder. It also has a name, familial cold autoinflammatory disorder, which is a bit of a mouthful to say, but we should try and move away from the somewhat pejorative names like Plaid, although it's so easy that it's almost we fall into it, right? The one question I had was, I've seen another kid like this. It seems that when you operate on them, it makes them worse, right? The the scar tissue gets worse. And if you had shown a full facial picture of this individual, it's very striking. He has no nose. He really very disfigured. Is that true? And how do you avoid?
Avoid that.
Yeah, I think it's probably. Internet is freezing form.
I can sort of, I think that, Phil, first off, thank you so much for presenting. You know, I'm not expecting, this room to experience another one of these patients and have the similar type of, problem. But I do think that it is a fascinating scenario because you're dealing with something that's extremely unusual that has, demonstrated profound destructive tendencies, and you're being asked to do something. So in this scenario, the not doing something was becoming increasingly more difficult because again, the pictures didn't quite capture it, but he's got some pretty significant atropine, and in the planning, the communication that I'm having is with the guy named Milner, I think is the guy.
Yeah.
And supposedly, by all accounts in the literature, he's the world expert on the subject. He is the authority. And, he's walking me through the evaporative test, he's like, oh, no, it's fine. And I'm like, can you show me how to do the evaporative test? I want to see it myself. I want to do it myself. I want to make sure that, trust but verify. And, his statement is effectively that, he's had the bone marrow transplant. He doesn't have this condition any longer. But it's a little bit frightening when you're being asked to take this patient to the operating room, and you really just don't know what's going to happen. We're in the operating room, and we're in the process of hooking up just the EKG leads. And I frankly had never seen him with his shirt off entirely, and I'm noticing some features of his skin about his shoulder, and I don't know if that is a new reaction to the anesthetic. I don't know if things are going downhill right now. So I'm like literally taking a picture of the skin and running out to the mom. I'm like, is this what is typically there? She's like, oh yeah. So from Milner's perspective, he should not behave like what Alex was worried about, like this person has this conditioning. And so that was what we were kind of hoping for, but we were really very concerned about it throughout the process, which is in part why we did one side, in addition to the potential for the need for a tarsorrhaphy.
Did you ever think about putting him on perioperative prednisone?
No, again, I'm taking it at this experts. He's like, he doesn't have this condition any longer. You're just dealing with the sequelae of it.
I think about it, right, because although you read this patient that we operate on right there you get just quiet, and they have to be quiet before they have surgery. And even if they are quiet, or immunosuppressed, I still put them on prednisone just to cover in case they have a robust inflammatory response.
That's for sure. It's in my mind, I'm thinking, is this sort of like OCD? Do I need to? And it's like, no, it's not. And you're looking at this person who's like profoundly disfigured because of this process. There was a leap of faith there.
Sometimes you just have to take the leap and do it. You don't know what's going to happen. I think the two main concerns in my mind for this are what you've already mentioned is recurrent inflammation. But the second thing is the underlying blood supply. What is the orbicularis and the underlying structures like, and will the skin graft take? Fortunately for you, fingers crossed, best possible outcomes, but you never know what's going to happen. This reminds me of some pyoderma granulosa patients that I've treated in the past, and we're like, who knows what's going to happen? But at some point, you've got them medically optimized and you just got to try and see what happens.
Good afternoon, everybody. Thank you, Dr. DiLoretto, for the introduction. And for today's case, we'll get to what exactly the case is, but I wanted to thank Dr. Gonzalez for giving me the opportunity to present this case. This is a patient that we actually saw together a few times over the winter. And so let's get right into it. On the first slide here is a little bit of anatomy, just as a refresher for what we're kind of going to be getting into here in a minute. So for the presentation, 56-year-old gentleman, he had 4 weeks of progressive left facial swelling and pain in the setting of a remote wisdom tooth extraction that was all for 3 months earlier. He had had several rounds of oral clindamycin as an outpatient post-operatively those 4 weeks before coming to an outside hospital. And he was seen at an outside hospital because his symptoms kept getting worse. And for 2 days, he was treated with IV clindamycin, and then he was switched to IV Unison, Zosyn, and Decadron. And despite these therapies, he didn't get better. His facial swelling continued to progress, and there was beginning to be concerns that there was involvement around the left eye. Because of this, and there wasn't a OMFS team at this outside hospital, he was transferred here. And he was started on a broader spectrum of antibiotics that included IV vancomycin, ceftriaxone, and Zosyn. Our team and the OMFS team were both consulted to evaluate the patient. Relating to his eye on this day of presentation, he said it felt tight. And with a different team, it was a little bit painful, and he felt like he had a little bit of blurry vision. Of note, on his laboratory workup, when he came to our hospital, he had a leukocytosis 29,000 with a neutrophil predominance, and there was no growth to date on any of his blood cultures, and there was really no other remarkable laboratories, and he was afebrile. And this is a picture of him on that first day. You can see kind of a lot of erythema extending from the cheek all the way to the upper lid, in fact, of that left side. And this is his medical history. So he has not a significant amount of medical history, but he has hypertension. He does have obstructive sleep apnea, but he was religious on his CPAP. He had a prior CVA without any sequela in 2015, and he had periodontal disease. His ocular history, he had myopia and presbyopia. He didn't have any prior eye surgeries, no traumas, no sinus surgeries, and no other oral surgeries besides that wisdom tooth extraction. Otherwise, he had a 35-year PAC use history. He wasn't a current smoker. And so this was the imaging study on the first day. I'm going to start with this because we're actually going to return to this a little bit later. And I just want to draw your attention to, you can probably imagine the red circle there. And specifically, you can see that there is soft tissue changes throughout the buccal and the infratemporal fossa area. And you can see on the right, this is a CT maxillofacial with contrast. That's the coronal view. Now we have the bone window on our right, and you can see the area of one of the wisdom teeth that was extracted along the maxillary bone there. And inferior, that below that, excuse me, we have the lower mandible wisdom tooth extraction sites. And so these two circles here represent the likely areas that our teams were believing was the culprit of everything that would happen to this patient. And before we get to the evaluation of what we saw when the patient came in, we actually have the benefit of multiple days of imaging studies leading up to the presentation that we saw. So we have a daily CT maxillofacial with contrast to show what was happening. That looking at December 8th, this is the same image that I had up before. Initially, there wasn't any concern about any involvement of the orbit, but I encourage you to squint a little bit and look in the inferior orbital foramen, and you can see some soft tissue thickening there when you compare it to the other side. And moving anteriorly below, you can see that there isn't really any changes. Maybe there's a little bit of fat stranding. If we were to call this an orbital cellulitis just by the imaging alone, this would be very, very mild. Moving on to the 9th, you could see that there is progression of these soft tissue changes. And now we can see a collection forming along the inferior, the orbital floor, past the inferior orbital foramen in the inferior fissure. And on the 10th, when we saw them, the disease is progressing. We now have involvement with the inferior rectus, and anteriorly, it's not looking good. You can see that it has almost covered that entire floor. And so on our initial exam, the patient's visual acuity was a little bit decreased. His pressure was normal, pupil exam was normal. He had some limitations of superduction and abduction. He was mildly proptotic. He had some erythema and edema, as you saw in the previous images. And he did not have any chemosis, a little bit of conjunctival injection. And he did have a small cup to disc ratio. Otherwise, his examination was unremarkable. And so he was diagnosed with presumed odontogenic orbital cellulitis. And his course would be a little bit of a roller coaster, but by the end of the week, things would be looking good. So after the initiation of IV antibiotics, both teams decided to prefer to observe rather than do any surgical procedures. His eye movements, proptosis mildly improved the first day, and the rest of his exam was stable. Second day was really rough for him. He had so much pus coming out of his mouth that he couldn't speak to his primary teams the first day and in the morning. By the time we saw him, he was a little bit better, but his eye exam was worse in many ways. He now developed chemosis. He had some proptosis that was worse from prior. And otherwise, his exam was stable. In fact, his visual acuity today was actually better. He was J1. We brought in 2 cefepime to cover Pseudomonas as well. And due to the clinical progression of this patient, our OMFS colleagues went in and performed a buccal, that's through the mouth, inferior mucoperiosteal incision and drainage with a drain placed to provide some source control. And they took cultures as well. And this worked to some extent. His eye felt a little bit better the next day, exam was the same. And on the 14th, we were looking at a successful therapy here and procedure. It was the best day he had in terms of his eye. His proptosis had improved. He still had a little bit. There was chemosis, but it was largely resolved. And his facial cellulitis was improving. He still had some limitations to his eye movements, though, and there was still some induration of that lower lid. But things were looking good. And we did start him on caspofungin per our ID colleagues because there was a yeast that grew from the OR cultures that was nonspecific. Unfortunately, things took a turn the next day. We were paged to the bedside in the morning for worsening eye pain, which we were a little bit surprised to hear, but we went to evaluate the patient. And as you can see here, his examination was very concerning for a compartment syndrome. His vision had deteriorated to J16. His pressure was now 35. His pupils were sluggish. His left pupil was sluggish, and he had significant ophthalmoplegia in the left eye. He was more proptotic, and on dilated examination, we really didn't wait for a full dilation. We were going right to the nerve on that. He had 3+ disc edema. Because of this, we performed a bedside lateral canthotomy and cantholysis, and his IOP reduced to 10. And 1 hour later, on a repeat check, his vision had improved from the J16, not to baseline, but to J3. Given this, we decided to get another contrast study. His kidneys had a little bit of a break. And so we can see that I just wanted to show you on the CT maxillofacial images here of the coronal view with contrast. You can see the continuation of that infection climbing up and extending through that inferior orbital foramen along the orbital floor, where the eye would be in the middle image is largely inflammatory fat stranding and soft tissue thickening. And then finally on the sagittal view here, I hope you can really appreciate, you can almost see tracks of what this infection kind of went through in climbing and anteriorly navigating this gentleman's left orbit. And because of all of this going on, Dr. Gonzalez took the patient that day to the OR. And Dr. Gonzalez, I was hoping you could speak a little bit about what you saw when you performed that orbitotomy.
Yeah, so, a couple of things that I think are interesting here. Number one, the age, whenever we think about orbital cellulitis, by and large, of course, it's a pediatric disease. Of course, it can happen in adults. And when it does, it's usually pretty bad acting bacteria that are involved. Similarly, odontogenic infections are notoriously difficult to clear. And again, oftentimes we'll have anaerobic or mixed flora slash causative agents. And so, knowing those things, and then the other component is that usually, if you have an odontogenic infection, you're going to have a more direct course through the maxillary sinus. And so none of this, it was a very unusual presentation of an orbital cellulitis in that regard. And so, very low threshold for operating. That's the reason why we went. And, following the imaging study, we knew exactly where the money was, located there in the infralateral orbit about the inferior fissure, orbital fissure. I'll be honest, I had a little bit of difficulty convincing the OMFS folks that this was actually coming from the odontogenic infection. They're like, we don't, it's not going through the maxilla, because again, if you were to look into the literature on odontogenic infections, that's how it's supposed to go. And they joined us in the OR at the same time. Going into the orbit, it was sort of just as you would expect, where there was this sort of phlegmon type component located closest to the infraorbital fissure, with more anterior, more active pus extending more anteriorly. So again, the imaging captures well the evolution and the intraoperative experience. And so, you can just see sort of the flagrant necrotic material passing down into the infraorbital fissure. So in addition to doing the drainage, in addition to doing culture, also created a little bit of margin by doing some decompression there into the maxilla, the maxillary sinus, to create a little bit more space.
Thank you, Dr. Gonzalez. And our OMFS colleagues, they went in a somewhat atypical approach retromandibularly to apply an additional drain, and they did a little bit more of an extended incision and drainage into the infratemporal fossa on that return after Dr. Gonzalez's portion. And the next day, the patient's visual acuity improved to J1, and we'll return to kind of what happened with him in a little bit. But first, a little bit of discussion about what this patient had, and I'm going to start broad before we kind of drill in on odontogenic orbital cellulitis. And going over orbital cellulitis, I know that we've all seen it, but some key features just to remind everybody. The big thing is if there's fever and leukocytosis. Those are key factors that can really help you distinguish between orbital cellulitis and some of these other conditions that can cause proptosis, pain on and restriction of extraocular movements, chemosis, and potentially more problematic complications relating to an afferent pupillary defect, color vision changes, or compartment syndrome. And those would include thyroid eye disease, sarcoid, GPA, orbital pseudotumor, and neoplasias. And Dr. Gonzalez hit on this a fair bit, but risk factors for kids, it could be healthy kids that get this. They don't have to have any underlying condition to get it. Of course, sinus disease is the most common etiology of orbital cellulitis. 90% of cases, a lot of literature will cite, is from sinusitis. But there's for adults, healthy adults should not get orbital cellulitis. There isn't a good reason if you are a healthy person, you should be having orbital cellulitis. So if you see somebody without any of these predisposing factors, maybe think about another element on the differential. But any kind of insult or infection or chronic inflammation to areas around the orbit are going to predispose you to getting these infections. So that could include sinus surgeries, oral procedures like our patient, infections or trauma to those areas. And then, of course, if you are in an immune compromised state or you have diabetes, you're at increased risk as well. In kids, it's your typical sinus bacteria, including our gram-positive strep and staph species. And then in adults, it's often polymicrobial. It's often more sinister bugs or bacteria. And sometimes you don't even get an isolate from it. And briefly, at least as a second-year resident on consult service, I know that I've certainly referred to the Garcia-Harris criteria a fair bit. I will admit I had not fully read the paper before, so I wanted to give everybody a brief overview of what that actually is because we apply it so frequently. And this was a study that was done on 40 patients, and they were all under the age of 9. And so there are no adults in that study, and it was a case series over 10 years in Wisconsin. And the percentage of patients that had a subperiosteal abscess that needed a procedure done to drain it was 10%. Okay, I want you to keep that number in mind when we talk about odontogenic infections in a second. Needless to say, I kind of condensed all the criteria right here. If we were to apply it to our patient, he's older than 9, and he has signs of a dental origin. Depending on what timeline you look at and which day, he didn't really have a true subperiosteal abscess initially, but he did eventually develop one. So he did meet the criteria for surgery eventually, but again, it's just supposed to help guide. But let's hone in a little bit on odontogenic orbital cellulitis. It's about 5% of all orbital cellulitis. And because of that, there's not as much large case series like the Garcia-Harris paper on it. In particular, this paper by Youssef et al. In 2008 over at Wills, they had, I think, the largest case series I could find with 24 patients with odontogenic orbital cellulitis. And their findings were pretty remarkable, I would say. One is that this kind of infection is vision threatening on the scale of orbital cellulitis. 45%, almost half of their patients had light perception or no light perception by resolution of their infection. And a different study that looked at 35 patients of different kinds of orbital cellulitis, the majority of the poor vision outcomes, odontogenic, okay? And that just shows that this can be a very bad infection. The risks that they were able to show clinical or statistical significance for were male gender, as well as vision changes on initial presentation, meaning that the infection had already migrated to the orbit, and the need for surgical drainage and multiple procedures. Abscesses form frequently, and in other papers, they cite that a procedure is needed in most cases eventually, whether it's from the OMFS teams or the oculofacial plastics teams or both, 60 to 90% of the time. And the papers have looked at different factors to try to predict which ones are going to be more aggressive, which will need procedures, and there's no consensus. There's just not a ton of data out there. And I wanted to show a couple cases to say that, well, maybe there is a little bit of a pattern to odontogenic orbital cellulitis with an N of 2, because on the left here, we have this case of a 49-year-old gentleman with no significant remarkable past medical history who had just 4 days of periodontal disease. They improved with some IV antibiotics. They got some dental drainage while they were in the hospital. They got a lot better. And then in 6 hours, they went to a compartment syndrome. And they had a resolution with the same set of procedures that Dr. Gonzalez did. And on the kind of opposite end is a somewhat atypical case, I thought, where a patient had some dental pain, couldn't see his dentist because of COVID-19 at the time. And he developed a rapidly progressive bilateral pre- and post-septal cellulitis. And his vision had decreased to 2150 NLP. And sorry, worse than that, and that was the end of his infection. That's where he was left at 2150 NLP. And so it can kind of have a broad range, and it can be really aggressive. And kind of in our case, it can sneak up on you. And I want to thank my fellow oculoplastics co-resident right now, Dr. T, for lending her perspectives from the OMFS side on this case. And a couple notes that she kind of delivered to us were, one, clindamycin as a periodontal agent, it is still somewhat used, but it is not very effective, especially in the northern US. A lot of antibiotic resistance. They usually use augmented. Additionally, flossing is really important. And the reason that I say that, okay, is because of the risk of postoperative complications from OMFS surgeries, especially wisdom tooth surgeries. This patient, I said we'd return back to our initial imaging, and I kind of skipped the dental signs because he had signs of pretty severe periodontal disease. We have apical radiolucencies. That's the top circle here. Again, this is that CT study from the 8th in the bone window that you can see where there is a little bit of less signal intensity at the very end of the bone at its root. And there's tartar throughout his mandible along his teeth. So in Europe, actually, they make patients floss for 3 weeks before any oral surgeries to reduce risk of complications. And the other note that she had is that when we're doing these kind of procedures, or when they're doing their exploratory incision and drainages, as they ascend superiorly along the bone in that mucoperiosteal border of the maxilla, it's a high-risk area. You're pushing on bone and you're pushing superiorly. If you push too hard, you can take that periodontal bacteria and send it straight to the pterygoid fossa, or the pterygopalatine fossa, the infratemporal fossa. And as you saw, in that kind of anatomy review, you are right next to the orbit at that point. And lucky for our patient, I wouldn't say lucky, but unfortunately, he did not have this infection decide to take a posterior turn towards the cavernous sinus. But it certainly can do that very easily, getting to the pterygoid plexus. And so the big takeaways I wanted to kind of leave you all with is that, one, odontogenic orbital cellulitis is an aggressive and a vision-threatening form of orbital cellulitis, and it can be kind of unpredictable. And frequently, it needs surgical intervention. Additionally, the inferior orbital foramen is an important passageway that is sometimes forgotten for orbital cellulitis. If you have a patient that has sinus disease, be sure to check the back, because 10% of the sinusitis are caused by an odontogenic source. And so you still need to consider if this is odontogenic, because that changes how we think about how aggressive that orbital cellulitis may be. And then dental history is key in the evaluation of it. If you have a patient, again, with that sinusitis, make sure there isn't some kind of dental component at work here. And engaging the ophthalmology and OMFS teams early is critical in source control here, because we had a good communication with them when we did have that compartment syndrome develop. We were able to easily kind of have them join us, and the patient, there we go. And the patient ended up doing well. His cultures from the orbit never grew anything, but sure enough, he did have some clindamycin resistant bacteria, and he had some normal fungal flora. So he was started on Augmentin, which they were all sensitive to, and he was discharged on the 20th in time to go home to his family for Christmas. And he's been doing well. He's not out of the woods yet. He still actually needs to see his OMFS team today, and he has a follow-up with infectious disease, I think, this month. But we saw him again in January for a left canthoplasty to repair the lateral canthotomy, and his eye was looking much better. So just a couple of questions I had to throw out to Dr. Gonzalez, Dr. Cho, and anybody else who'd like to comment on this. But how have these odontogenic orbital cellulitis diseases differed from the variants of the orbital cellulitis that you typically see? Are they always aggressive? Have any kind of come back and really roared like this before? And then the other question would be, what could be done to potentially, now we know how this went, to try to avoid this rapid decompensation in orbital surgery? Or is odontogenic orbital cellulitis something that you kind of have to watch and wait? And I pose this to you again. Garcia-Harris criteria was built off of a case series where 90% of the patients didn't need a procedure. If you could, based off of, let's say, cases like this and what you've experienced, what kind of criteria would you make? If you were to do the Cho Gonzalez criteria, what would be on it in terms of thinking about when this patient needs to go to the OR besides something like a compartment syndrome?
Thank you, Greg.
I think in retrospect, knowing that these odontogenic infections have a tendency to migrate through the infraorbital fissure and straight into the posterior orbit, which is why they have a tendency to be more vision threatening. You might consider doing an orbitotomy earlier when you start to see infiltration of the posterior orbit, even without the presence of an abscess. Maybe you could consider, going in and just doing orbitotomy, irrigation with antibiotics and everything to try to head this off at the pass. That's not based on any, data, of course, but given how often these cause loss of vision, something to consider. Very nice job, though.
I was curious if we asked we have a OMFS resident on service, if they had talked about any additional approaches or any additional interventions that they would now do, on Monday morning, so to speak, that could have potentially prevented its continued advancement more towards the orbit. I didn't get a sense that they had a better play in mind.
I think they did everything they could.
Yeah.
It seems like they did what was available as possible. So.
Which in a way is kind of, frightening.
Yes.
For sure. And definitely lends credence to the idea of an earlier orbitotomy there. Definitely a bad actor, but.
And so I'm Alec, one of the BGY3s. Thanks for coming to take a listen to our cases today.
We can't
Okay.
hear you.
Oh, I'll talk a little louder. And so we'll just jump right into the first case. We have a patient, she's a 2-day-old female, born at 39 plus 1 weeks via C-section due to breech presentation. Ophthalmologist consulted just on day 2 of life because they were concerned about the way that right eye was moving. As far as history, there's not a lot. She was just born. And so as far as birth history and pregnancy history, uncomplicated other than that breech presentation that we mentioned. Importantly, family history, there's not really any significant medical or genetic problems in the family. Going straight into the exam, we can see why that they wanted us to see this little one. And so vision appears fine, wincing to light, the pressure is soft by palpation. Pupils are importantly without anisocoria, no APD present. But what we can see is that on the external exam, there's some ptosis on the right side, along with some enophthalmos. But the remainder of the anterior portable slit lamp exam, the dilated fundus exam at the initial presentation was normal. And here's what they were saying about the eye moving. And so there's profound limitations in supraduction, adduction, and then mild limitations in infraduction and abduction. There's an exotropia present, and that right eye is definitely sitting lower than the left. Putting everything together, I hope that some alarm bells are going off in regards to the way that the eye is limited in its movement and the ptosis that is present, that we could potentially be dealing with something going on with that third nerve. And so we can see these pictures here. They do a little better job than I think the description I just gave, where you can see the enophthalmos along with the ptosis. This was an early picture in life, I think, within that first week. It's kind of hard to tell the light reflex on these blown up images, but that eye is definitely sitting a little lower and there's an exotropia present. Here's a picture when she's a little older. We're getting a bit of a side eye here, but we can still see the ptosis along with the enophthalmos. And so like I alluded to, I was hoping that our alarm bells were going off for the potential of a congenital third nerve palsy. It's pupil sparing at this point. Nobody made note of any anisocoria on any of the examinations. Differential at this point, just while they're still in the hospital, includes something like a Horner's, maybe an early Duane's, a CPEO. Tumor is always on the differential. And so things that were done next included getting pediatric neurology involved, along with some imaging studies. Pediatric neurology specifically to see if there are any other neurologic deficits that could help us localize anything else going on with this little one.
Alec, is there iris heterochromia?
There is not. Good question though. As far as the pediatric team, neurology team, they had nothing else of note on their exam. They found what we found, which was the ptosis and the limitations in extraocular. So what was opted for next was a picture MRI of the brain in orbits with and without contrast. And this is what we actually see. And so we can see here on our MRI, this is an axial view. T2, we see this heterogeneous lesion in the posterior inferior right orbit. It's relatively large in this little one. It's 7/2. And then we'll see on the coronal, it's about 3 millimeters tall. It's actually along the course of that right infraorbital nerve, or at least where we'd expect that right infraorbital nerve to be. Here's that coronal view I was just alluding to. And then we can see a little bit better on this, so I can keep it there for a second, yeah. But then on this coronal view, we can see here how that eye is sitting a little lower on the right compared to the left, and then what's made known in the radiology report, and you can see it here, that eye is also got these hypoplastic extraocular muscles. I have even a hard time discerning where they are on the right, and we can see them on the left there. And so that, I don't think that's what anybody was necessarily expecting when ordering that MRI. And so neuroradiology at that point wanted another picture. They wanted us to get a CT scan to better characterize this lesion that we found in this young one in the orbit. And so that's exactly what they did, was a CT scan of the brain in the orbits with and without contrast. We can see that same lesion here on this axial view. This is that CT scan, soft tissue window. We can still see this heterogeneous or this hypodense lesion. And actually here we can see this calcific stalk that's kind of branching from the aeroscience to the sphenoid. And then again, we can see it here on this coronal view, just how posterior we are in the orbit. And so, what are we thinking about a differential diagnosis here? I know that, like I mentioned, I don't think this was the first thing that people were expecting to find was a mass in the posterior orbit. Some things that were on the initial differential, just based on the neuroradiology interpretation of the images, included a peripheral nerve sheath tumor, something that we can see like in folks with neurofibromatosis who have schwannomas, neurofibromas. Two things that they posed included thrombosed orbital barracks, orbital glia heterotopia. That's not something that we see named a lot, but I found a case report of one of those in the orbit that was a bad actor in a young child. Some other things that I was thinking about as far as younger lesions in the orbit, infantile capillary hemangiomas, anthogranuloma. Some other things I thought that I mentioned, and as far as somebody with of this age with a tumor in the orbit, unlikely based on the presentation, but still things you have to think about are things that could potentially kill the patient, including rhabdomyosarcoma, neuroblastoma, metastatic leukemia, things like that. But based on what we have so far, the leading differential as far as the appearance and the presentation would be a peripheral nerve sheath tumor. Just to go over quickly, kind of the things that we think about with this, it's a heterogeneous group, mostly benign tumors, fortunately. Some may occur sporadically, but some may occur in association with things like neurofibromatosis, specifically neurofibromas, schwannomas. And management is interesting because it's really just dictated based on your suspicion of malignancy versus whether it's benign. And then for us in the orbit, in this small space, we have to think about potential mass effects from the effect of this tumor, and whether or not that plays a role in how we go about dealing with this. Here's a more comprehensive list of those nerve sheath neoplasms, from the neurofibromas to the schwannomas. And all the way down at the bottom, we have the malignant stuff, the malignant peripheral nerve sheath tumors, otherwise known as neurogenic sarcoma, and then malignant granular cell tumor. And so I actually wanted to pause here because this is kind of where we are. We're kind of right in the middle of this case. And so interesting presentation, interesting picture, interesting patient. And so I kind of wanted to pose to the audience, to being both plastics, maybe even a little pediatrics here. Next steps, you know, one of the things that I think we all learn on the plastic service is that just because you can do something surgically doesn't mean that you should. And so if we're thinking about something like a biopsy and surgical intervention, when do we do it? How do we do it safely, considering this is a patient who's less than 1, risk of general anesthesia, systemically they're doing well otherwise, or any other problems ongoing with the child, other than what's going on in the orbit. And then things on the pediatric side of things, as far as the strabismic amblyopia, possibility with the way the eye is deviated currently, and something that wasn't made on initial presentation, but on later presentation in the office. There's now a question of questionable pallor of that optic nerve in the right eye. And so now having to weigh and consider whether or not compression on the optic nerve is going to have any play on the way in which we go about this. Another consideration, something I failed to mention on the imaging studies, was Dr. Gonzalez had mentioned in one of his notes that one of the things that may be in play is that there may be some tethering of those infraorbital structures, and that potentially going in and doing a biopsy and releasing those things could help the eye move. And more generally, how close we need to watch this kid, whether we do surgery or not.
Yeah, thank you so much for mentioning that great presentation. So one of the things on the clinical examination, coming into the room, it sort of looked like potentially a congenital third nerve type of picture. The things that were sort of suggesting a tethering type of mechanical effect, there's the thalamus, and then there's the degree to which the levator excursions are at play. And so there's relatively good levator movement. So that sort of begged the question whether or not it was a nerve thing or whether or not it was a mechanical type of limitation. So the levator excursions were disproportionate to that of the eye motility. But yeah, totally open to suggestions here.
Please. We saw them just this morning, right?
Yeah, that's all the answers.
It was supposed to have a repeat MRI this morning, but they had a cold last week, so they got here.
Any hearing issues?
As far as I know, they passed their hearing screening.
Like some cartilage stuff right on the ear that needed some remodeling, but no hearing.
They had one side of the ear that was abnormal, deformity of the external ear, but as far as hearing, I think they passed.
One question, as Alec was saying in the imaging, it appeared that the muscles in that orbit were not there. So in your opinion, is it that they're missing or that they're tethered?
No, I think that the muscles are there. They probably are a little bit hypoplastic. I don't know if there's been some arrest in the development
Right,
of
that's-
this sort of tethering. But I'm curious, if we think that we're going to end up doing a surgery, do we go for the strabismus surgery right off the bat? Do we potentially go in, do the separation, perform a biopsy, and perhaps even if we don't get complete resolution of the strabismus, perhaps that gives us more play in the strabismus solution. So yeah, I'm expecting there's going to be some movement with eye muscle
Okay.
after.
It was really interesting after Dr. Gonzalez saw the kid, just kind of opened up these new possibilities. We have this tethering, we have pretty good lid functions, and we do have a reason for the enophthalmos. But we've got lid function, but then we don't see those muscles as well developed, and considered if there's a chance that maybe we just had an effect on the inferior branch of the third nerve, kind of just hitting some of those muscles, and maybe the levator is still functioning. I don't know.
And Chappelle's been neural crusty, CCDB, so many. The smell I have.
You've seen a lot of patterns, for sure. Proposals.
There's definitely something weird going on. I mean, full disclosure, I don't treat kids, so you probably have a much clearer vision of where to go with this. But I guess the main issue for me is the lesion. Do we need to do anything about it? I mean, do we think it's malignancy? I mean, for a kid like this, a young kid, the chances of it being a primary malignancy are pretty low. You have to wonder, could it be a metastasis from somewhere? But I'm sure the kid's been imaged up and down. So I don't know. I don't know the answer. It looks very posterior, right, on the imaging. So there's some risk involved for sure. It's a tough one. Good luck.
Yeah, so no other, nothing in the family. The kid doesn't have any other skin lesions, so it doesn't meet any criteria for neurofibromatosis.
In one of your notes, Dr. Haney, did you mention that Dad maybe had jaw winking as a kid that resolved?
Yeah, so the dad mentioned
Yeah.
this to me just
Yeah.
a little bit ago. He said, "Oh, I had something about a jaw wink as a kid, and it went away." It was a vague history. He didn't have any photos or videos for me.
Is there any component of this in the pterygopalatine fossa of this lesion?
Not that I'm-
I was not able to appreciate any that inferior. It appeared to be.
Because that might be another surgical approach, possibly. It would be go to an ENT and they could do a transmaxillary or some other approach to, if just you want a tissue biopsy, that would be an.
That's actually a good approach that, if you ultimately go surgical, it would be a combined case. With one of my rhinologists, and then basically at cruise along the floor, just basically look to separate osteoflap to make sure they're safe. And then have them take from below.
Great, and so that's what we're doing, and so we're watching. The patching's going well according to Dr. Haynes. When the patch is on.
It's really painful to just patch third nerve, like to just not touch, just let it be and just patch it. But from what the parents say, you patch the other eye and the kid's just as interactive and happy and kind of moves the head around to look at things a little more, but they've been patching. We started off patching kind of half of the kids' waking hours. It's so we're kind of just holding the pattern right now, but
The one thing I would add is I'm just wondering, has this kid seen neurogenetics, or maybe could see me to get a good physical exam to make sure there's no stigmata of anything else on the body that may be helpful in coming to a diagnosis?
they've not seen you, but they certainly can, I'm sure.
Have they seen neurogenetics?
Not any genetics notes that I could find.
So I would suggest they either see me or neurogenetics either. Sometimes subtle clues could be elsewhere in the body, as you all know, and I'd like to make sure that's not something we're overlooking.
Great idea.
Interesting case. Well done.
All right, thanks for staying for the future lecture, everyone. It's my pleasure today to welcome and to introduce Dr. Raymond Cho, who was born in Virginia and raised in Toledo, Ohio. Graduated from the United States Military Academy in West Point in 1990 and from the University of Cincinnati College of Medicine in 1994. After completing his general surgery internship at Brooke Army Medical Center in San Antonio, Texas, he spent 3 years as the brigade surgeon for the 1st Brigade 82nd Airborne Division at Fort Bragg, North Carolina. He then completed his ophthalmology residency in 2001 at the San Antonio Uniformed Services Health Education Consortium. He served as chief of ophthalmology at Ireland Army Community Hospital in Fort Knox, Kentucky for 2 years, and at Keller Army Community Hospital in West Point, New York for 4 years. He also deployed to Balad Air Base in support of Operation Iraqi Freedom from 2005 to 2006, during which time he served as the ophthalmology consultant for the Iraqi Theater of Operations. Thanks for your service. Following a 2-year fellowship in ophthalmic plastic and reconstructive surgery at the University of Michigan Kellogg Eye Center, Dr. Cho was assigned to Brooke Army Medical Center from 2009 to 2012, where he served as assistant chief and chief of the ophthalmology service. He then served as the director of oculoplastic and orbital surgery at Walter Reed National Military Medical Center from 2012 to 2015, before retiring from the Army at the rank of colonel. His military awards include the Legion of Merit, the Bronze Star Medal, and the Order of Military Medical Merit. He also served as president of the Society of Military Ophthalmologists from 2013 to 2014. Dr. Cho has been the director of ophthalmic plastic and reconstructive surgery at the Ohio State University Wexner Medical Center since 2015 and is a clinical professor in the Ohio State University College of Medicine. He's an ASOPers Fellow and Fellow of the American College of Surgeons. He has served on several committees for the AAO and ASOPters and is a recipient of AAO's Achievement Award and currently vice president and president-elect of the North American Society of Academic Orbital Surgeons. He has authored or co-authored more than 50 scholarly articles, book chapters, and research papers and presentations, is on the editorial board of Frontiers in Ophthalmology, and is a reviewer of several major scientific journals. In 2023, Dr. Cho participated in 2 humanitarian mission trips to Ukraine to perform reconstructive surgery on wounded soldiers and civilians. He is highly sought after nationally and internationally as a speaker and consultant for his expertise in orbital surgery. It's our pleasure to welcome Dr. Cho as he presents the faces of Ukraine.
So my talk is going to be split into 2 parts. I'm first going to give a talk on periocular reconstruction, just some general principles, and then I'm going to flow into my description of my mission trips in Ukraine. So just a disclosure, I'm just getting over the flu. which I've been fighting off for about the past 3 weeks, which was complicated by H. flu bronchitis. And then on top of that, I was skiing in Utah 2 weeks ago and I suffered a left distal radius fracture. So it's been a little bit of a struggle for me, but I think I'm coming out of it on the other side. So when it comes to periocular reconstruction, there's many indications why you might need to do such a thing. Trauma, of course, is a very common situation. You have lacerations, you can have tissue destruction and loss in some cases, and burns in some other cases. Surgical trauma is also common. Tumor resections such as Mohs excisions of cutaneous carcinomas, congenital anomalies, and surgical misadventures, be it your own or other surgeons' surgical complications. And then cicatricial disease, such as one of the cases that we saw earlier today. It can be a cicatricial disease of the ocular surface or pyogenic pyoderma gangrenosum or other such unusual diseases. This picture is of a patient that I treated while I was a fellow. And this gentleman hit himself with a chainsaw in the face. And so if you hear that history and you look at this picture, you might think to yourself, there's no way that there's not some amount of tissue loss here. But in fact, when we got him to the OR and we looked at got all the pieces together, they actually came together quite nicely. I think the next slide is actually a picture of that. So, that's a picture from Iraq. I'm sorry. So there's a lot of questions that you have to ask yourself when you're looking to undertake a periocular reconstruction. Number one, if the lid is involved, is it a partial thickness or a full thickness laceration? In other words, does the laceration go through the lid margin? Is the tarsus involved? In which case, you're going to treat it in a different way versus if it was a partial thickness laceration. Is there tissue loss? As I mentioned before, sometimes it's going to be hard to tell in trauma. The lids are under a certain amount of tension, and oftentimes when there's a laceration, the eyelid tissues like to curl underneath themselves. And sometimes it can create the appearance of tissue loss when there actually isn't. So this is the actual patient that had the chainsaw injury, and you look at this and you're like, oh, there's got to be some tissue missing. But in fact, pretty much all the pieces were there except for maybe a tiny bit of necrotic tissue right here in the anterior lamella. What other structures are involved? Obviously, the globe is quite important to all of us in this room. Is there an open globe injury or some other injury? The globe is a canaliculus involved if it's a medial laceration. There's a levator involved. If there's fat coming out of the wound, then you know there's a violation of the orbital septum. The next structure underneath it, when it comes to the upper lid, is the levator aponeurosis. So you have to ask yourself if that needs to be repaired. And then lastly, how is the vascular supply? Now, in most cases of acute trauma, that's not usually much of an issue unless it's particularly severe. But in cases of secondary trauma, it can be a major concern. Have they had multiple surgeries in the past, such as a lot of the trauma or the cancer resections that we undertake? Has there been radiation? A lot of the ENT head and neck cancer patients that I treat have undergone adjuvant radiation, and that can very much complicate the results of periocular reconstruction. So some general rules of periocular reconstruction that you need to keep in mind. Number one, when it comes to the eyelids, no vertical tension on your repair. Replace tissue with like tissue whenever possible. So if you have tarsus missing, you want to replace it with something like tarsus. Tarsus from the other side is great. If not, you can use something else like auricular cartilage or hard palate mucosa or various other options. Make sure that there's an adequate vascular supply. If you're putting a graft, a free graft, you have to make sure that there's a good underlying vascular bed of tissue. You cannot put a graft on top of a graft because neither one have the vascular supply and they're both probably going to fail. Respecting aesthetic units is always a good idea. This illustration here shows the aesthetic is an illustration of the aesthetic units of the periocular region in the face. So if you're doing a flap, whenever possible, you want to make sure that you use different flaps for different aesthetic units. And then we're all familiar with the relaxed skin tension lines. If whenever possible, you want your incisions and your resultant scars to follow those relaxed skin tension lines for the best possible aesthetic result. So for full thickness eyelid defects, basically I like to divide them into small, medium and large defects. For small defects, say anything less than 10, 20, 25%, you can often just do a primary closure, especially in older patients who have a lot of laxity. Sometimes if you need a little bit more room, you can do a lateral canthotomy and a campholysis in order to just give you that, just a much less tension on your closure. For medium defects, anywhere from 30 to 50, maybe even 60%, depending on how old the patient is. Tensile flaps are often useful for this is classically described for the lower lid, but you can also do a reverse tensile flap from the upper lid. And then for large defects of the upper and lower lids, often lid sharing techniques are required. So for the lower lid, that's the Hughes flap, and for the upper lid, that's classically the flap. So when it comes to primary closure, this is how I like to do my primary closures. I usually put 2 sutures to approximate the lid margin. The first one is at the meibomian gland line, and the second one is at the posterior lash line. I like to do a vertical mattress because I like the wound edgy version that it produces. So this is kind of an illustration. So these are the 2 edges of the tarsus at 90 degrees. So the far pass comes first. That's about 2.5, 3 millimeters from the margin of the laceration. Your depth matches the length of the pass from the lid margin. Then you go on the other side, you match the depth and the size of the pass on the other side. And then you do your near passes, near, and then you sew them back together. So you just, it's important to keep the dimensions of these passes in mind. So the blue arrows are equal distances, and then the red arrows, which are the near passes, are also equal distances. So once you have those sutures in place, oftentimes I'll kind of leave them loose so I can still see the edges of the tarsus. This patient is, by the way, just a pentagonal wedge resection for trichiasis. And so the purple sutures that you see here are the partial thickness sutures. Can you see my? Yeah, there it is. Our partial thickness passes through the tarsus. All right, you want to make sure you don't go full thickness or else your suture will rub on the cornea. When it comes to the lower lid, because the lower lid tarsus is only about 4 millimeters in height, usually you can only get 1, maybe 2, if you're lucky, of these sutures. And for the upper lid, because it's about 10 millimeters, you can usually get 2, 3, maybe even 4 of these sutures in. And then once you have all that in place, you cinch down your sutures. This shows the popular mare's tail technique where you leave the margin sutures long and tie it down with your skin sutures. I actually don't do that. I just use a 6-0 roll, tie a couple extra knots in it, and then cut it very close to the knot so the knot doesn't rub on the ocular surface. And this is the patient's final result. So this shows a medium-sized defect. This is about a 50–60% defect of the full thickness of the lower lid after a basal cell carcinoma. So this demonstrates the semicircular incision that goes from the lateral canthus. It extends across the lateral canthus. You do a lateral canthotomy and if you're campholysis, and then that allows you to bring the 2 edges of the tarsus back together, do your full thickness repair like you normally would. Take a little bit of a standing cone out and then repair the anterior lamella. So this is a patient who required a Hughes flap after resection of a melanoma that involved the conjunctiva and the eyelid. This just shows ocular surface reconstruction that I performed with a umbilical cord membrane graft for the bulbar conjunctiva, and then a buccal mucous membrane graft to reconstruct the palpebral conjunctiva. And so this should just be a review for most of you, but the Hughes tarsoconjunctival flap is taken from the upper lid, leaving at least 4 millimeters of the upper lid tarsus behind, make a full thickness incision, dissect the tarsus off of the underlying Mueller's muscle, leaving a bridge of vascularized conjunctiva. You bring the flap, so here's the tarsus coming down into the lower lid, attached to the inferior lower lid retractors, and then a full thickness skin graft is placed on top of that. So this is a pre and post op from a different patient with a basal cell carcinoma after a Hughes flap reconstruction. For the upper lid, the Cutler beard flap is classically described, although there are other options, but this is a patient who had a large keratoway canthoma of the left upper lid. I did a resection with frozen sections. And then I actually like to use nowadays a modified cutlery beard flap. The classic cutlery beard flap is where you take flaps from the anterior and posterior lamella, bring them up into the upper lid, and then put a graft to a tarsal substitute graft in between those two layers. What I do nowadays is I take a pre-tarsal conjunctival graft from the opposite upper eyelid. I'll use that to reconstruct the posterior lamella, and then I'll bring the anterior lamellar flap from the lower lid. So this is the tarsal conjunctival graft, and then this is the anterior lamella, skin and orbicularis, brought up through a full thickness incision underneath the tarsus to reconstruct the anterior lamella. This is another patient who had that modified cutlery beard flap, had a full thickness loss of his upper lid from trauma, which was never reconstructed. You can see this large amount of black ophthalmos. This is him in the interim before his flap was taken down. And then this is his post-operative result with full eyelid closure. So when it comes to partial thickness defects of the lids and paraocular region, there's many options that we have in our toolbox. You can have basic advancement flaps where you just move tissues around. You can do rotational flaps, which pretty much the name describes it pretty well. Transpositional flaps, where you have flaps that are moved from one part to another, but that kind of skip over tissue. And then interpolated flaps, the classic example being the paramedian forehead flap. There are also subcutaneous flaps that are available if you want to put a skin graft over top of it, or if you just need to provide reconstruction of the subcutaneous tissues. Temporal parietal fascia, temporalis muscle, and pericranial flaps are just a few examples of those. So, and there's also microvascular free flaps if you have large soft tissue defects. And of course, this requires a specialist in microvascular free flap reconstruction, where you bring a vein and an artery along with a flap of skin and sometimes even bone, and you connect it to a donor vessel. So the simplest way to close a defect is just to ellipse out the excess tissue and then close it back together. This is an example of an O to U reconstruction, where you're just taking a flap from one side of the defect and bringing it in. This is an example of an O to H, where you bring flaps in from both sides and they come together to form an H. O to T, similar concept, except you're just making an incision on one side. You're not making the incisions on the bottom here. O to S and O to Z flaps are two other examples of advanced flaps. This is a W-plasty. I don't really find much use for W-plasties in my practice. I don't know, Mithra, if you use the W-plasty very often.
Sometimes I'll do it for telecanthus soft tissue, but it's not the most common.
So this is an example of an O to Z flap, patient with an anterior lamellar defect of the preseptal lower lid. And the reason I did an O to Z instead of an O to H or O to T is because this more closely follows the relaxed skin tension line. So you have this triangular flap on this side, another triangular flap on the other side. They come together to meet in the middle, and it provides a nice aesthetic reconstruction. Rhombic flap is a very popular transpositional type flap. What you do is you basically imagine or create a rhombic defect. And then you have four choices. You can either go up like this, you can go on this side, you can go down here, or you can go down here. And the key is to make sure that these distances, this distance from here, these are basically like two equilateral triangles. So this distance equals this distance equals this distance equals this distance equals this distance here. So this distance from here to here is also the exact same thing as here, and then this distance is the same here. And you basically create your flap and you rotate it in, and you end up with a scar that looks something like this. A bilobe flap is another example of a transpositional flap, a little bit more complicated. So this is your primary defect. You're creating another rotational flap that's a little bit smaller than your defect, and then you're creating a second flap that's a little bit smaller than this to reconstruct the secondary defect. So this flap rotates in here, and this flap rotates in to reconstruct the secondary defect. So this is an example of a lateral canthus defect after a Mohs surgery, showing the rhombic flap. So this is kind of how I imagined that defect to be. I decided to take my flap from up here because I didn't want to take it here. That would have distorted the brow. I didn't want to take it from here or here because that would have created downward tension on the lateral canthus. So here's the patient's post-op result. Here's an example of a bilobe flap. I used the bilobe here as opposed to rhombic because there really wasn't any good options for rhombic because it was closer to it was actually involved the pretarsal lower lid. So here's the primary flap here, and then this is secondary flap to reconstruct the secondary defect. And here he is immediately post-op. Here's the primary flap, secondary flap, and then here he is post-operatively. Another flap I like to use, particularly in the medial canthal region, is the island pedicle or V to Y flap. This is a flap where your vascular supply comes from deep underneath the flap. So you actually do make full thickness incisions all the way around, but you keep a pedicle of vascularized deep tissue here, and then you advance your flap into the defect and then close this behind. And so that creates a V to Y reconstruction. Rotational flap, very simple concept. You just create an arc and then rotate the flap into the defect. Remove a little standing cutaneous deformity here and here, and that's what you're left with. So this is an example of a medial canthus defect where I use a glabellar island pedicle flap. I keep the deep tissue here as a vascular supply, make incisions here and here, advance the flap into place, and then here she is at the end of surgery. Here's an example of several different flaps being used at the same time. So this illustrates the concept of respecting your aesthetic units. So here's a squamous cell carcinoma that underwent Mohs reconstruction. You can see he has defects of the medial canthus, the medial lower lid, and the medial upper lid. So I don't want to use one flap to reconstruct all three of these. I use 3 different flaps to reconstruct each defect separately. So here is a flap from the upper lid and just a simple advancement flap brought over to here and attached to the medial canthal tendon. Here's a flap from the lower lid, subciliary incision, again, same concept. And then here is your glabellar island pedicle flap that I just showed you to reconstruct the medial canthal defect. Here he is at the end of surgery, and here's his final post-op result. Cervical facial flap is sometimes required to reconstruct very large defects of the skin of the lids or periocular region. This is a woman who underwent removal of a melanoma from the cheek, and so this flap extends all the way across the lateral canthus, the preauricular region, and down into the neck, hence the cervical facial flap. So this entire flap is undermined in the subcutaneous plane, rotated into place. This is a standing cutaneous deformity that's removed. This shows the flap being developed, sutured into place, and here is her final postoperative result. The one caveat that I would say that is if you're using a cervical facial flap, if there is a significant amount of preseptal or pretarsal lower lid skin that's missing, you're likely to, if you just do a cervical facial flap, you're likely to get a good amount of lower lid retraction. So I will usually combine this flap in those cases. If this defect were any higher involving this part of the lid, then I would usually place a skin graft to reconstruct that part of the eyelid. So this is an example of a paramedian forehead flap. This patient underwent a reconstruction of a defect by another surgeon. That reconstruction failed. And so he ended up with this defect of his lower lid. What I created was a flap based upon the supratrochlear artery here, extending all the way up to the hairline. This flap is then brought down into the defect and sewn into place. And this is an example of an interpolated flap. So there's a portion of the flap that's not reconstructing any of the defect. It's bridging over normal tissue. And so this is done as a stage procedure. So once this has had a chance to vascularize over about a month, sometimes longer for patients who are higher risk for failure. And then you take them back to the OR. You remove the portion of the flap that you're not using, and then inset the proximal portion in the brow. So finally, as far as grafts go, sometimes you can't do everything you need to just with flaps. And so for anterior lamellar reconstruction, the most common thing that we use is skin grafts. In order of preference, upper lid is great for any lid defect because it's lid skin. If you have an older patient who's got a lot of extra, you can use that. But if they're younger or if they have a defect that's larger than what you can get, then you got to go other places like preauricular, retroauricular, or supraclavicular. So these are probably my most common locations. After that, you can pretty much go wherever you need to. But the closer your donor site is to the lids, the better skin match, the thickness match, and the skin color match that you're going to have. As far as posterior lamellar reconstruction, autogenous grafts are obviously the most preferential. Tarsoconjunctival grafts, like I mentioned with modified cutler beard flap, hard palate mucosa grafts for the posterior lamella, buccal membrane grafts, or dermis fat grafts. Other grafts that are available, off-the-shelf grafts such as Enduragen or Alloderm, amniotic membrane. I have, like I showed you previously on that melanoma patient, I have used umbilical cord membrane. You can use amniotic membrane as well, but the problem with amniotic membrane is that it's very thin and it usually goes away within a few days to a week and it doesn't last very long. The umbilical cord membrane has the same advantages of as amniotic membrane, but it's 10 times thicker than amniotic membrane, so it tends to stay in place a lot longer and you get a more durable reconstruction. These grafts are not meant to stay there forever. They're just there long enough for the new conjunctiva to grow over the defect. And then you have other options that I never utilize, like Medpor, Gore-Tex, and others. I don't like the idea of using alloplastic implants for posterior lamellar reconstruction. So this patient is a burn patient, firefighter that I treated when I was in San Antonio with both the skin grafts to the upper lids. So here's a patient who had actually had a squamous cell carcinoma and a basal cell carcinoma of the same cheek. And so that was reconstructed by ENT. He came to me with severe cicatricial ectropion. So I used a supraclavicular skin graft to reconstruct this defect after I released the scar tissue. And this is fairly early, I think 6 weeks afterwards, but he ended up doing pretty well. Just to be mindful that when you use a very large both in a skin graft like that, it does contract. All skin grafts will contract to some extent. And so the larger your skin graft is, the more contraction you're going to get. So I told this patient, listen, I'm going to put a huge skin graft on you. There's a very good chance that it's going to contract and you're going to need some further revisions down the road. But fortunately, he did pretty well. So just as a wrap up, these are kind of this kind of list of the periocular reconstruction techniques that I talked about when it comes to full thickness defects. You can just do a primary care repair. You can do a lateral cantotomy lysis. Tenzel flap is great for medium-sized defects. Hughes flaps and cutler beard flaps are very useful for large upper and lower and upper lid defects. You have a variety of local flaps that are available for consideration, and then a number of different grafts that you can use for periocular reconstruction. Thanks. I'll take some questions before I move on to the next presentation. Any questions about that?
There's an ever-going discussion on the use of ice after full thickness grafting. Do you have any sort of thoughts or rationale behind your perspective?
I don't use ice after grafting. In fact, most lap reconstructions, I just tell my patients, just stay away from the ice because I want the vascular supply to be as robust as possible. Do I have to share again?
Yeah.
Okay. There we go. Okay, so as David mentioned, last year, I participated in two mission trips to Ukraine. So I appreciate the opportunity for me to talk about those trips for a couple minutes. I have no financial interests. Please, you can take photographs, but don't take any ones that include pictures of any of my patients. So when Russia invaded Ukraine, the full-scale invasion of Ukraine was in February of 2022, so almost 2 years ago. Since that time, casualties in Ukraine have been tremendous, absolutely horrific. Amongst the civilians, they estimate that 10,000 have been killed and at least 18,000 have been injured. Among the Ukrainian military, the Ukrainian government does not release official statistics, but as near as from American military estimates are that about 70,000 Ukrainian military have been killed and about 100 or 120,000 have been injured. Amongst the Russians, that number is believed to approach 300,000. So there's just been an incredible human cost to this war in Ukraine. When it comes to facial injuries, there's no way to know exactly how many facial injuries are involved with these numbers, but if you take numbers from past conflicts and extrapolate them to the current conflict in Ukraine, and you make the assumption that up to 40% of combat injuries involve the face in some way, then you're looking at somewhere in the neighborhood of 50,000 Ukrainian soldiers and civilians who have some sort of facial trauma that needs to be treated. Clearly, the Ukrainian healthcare system is not equipped to treat this massive, overwhelming number of facial trauma patients. I don't even think the United States could deal with that many facial trauma patients. Many of these injuries are sent because they can't handle them in Ukraine. They're sent to neighboring countries like Poland and Germany. But in September of 2022, the American Academy of Facial Plastic Surgery decided to send a team of facial plastic surgeons to Ukraine, which to my knowledge was the first mission trip of American surgeons to go to Ukraine to try to give, to aid in the treatment of these patients. This team went to Ivano-Frankivsk, which is the same location that we went to, but this was kind of like the very first time that American surgical team set foot in Ukraine. Face the Future Foundation is a nonprofit based in Toronto. It was founded by a ENT facial plastic surgeon named Peter Adamson in 1996. They have over the past couple decades performed over 50 missions in Africa and Asia. When Peter recognized the need in Ukraine for facial reconstruction, he decided that he was going to try to do something about it. And so he partnered with Razum for Ukraine, which is a non-governmental organization based out of New York, mostly Ukrainian expats who try to aid with providing humanitarian assistance and medical aid to Ukraine. So this was the first, in March of last year, was the first mission that Face the Future Foundation had performed in a war zone. So they started planning in about September of 2022. They interfaced with a local ENT department in Ivano-Frankivsk. They started to collect patients. The ENT folks would put pictures and CT scans in a Google Drive, which that could be shared with the surgeons. And then on a weekly basis, they would review these cases and determine, okay, this is probably what we're going to have to do to treat this patient. A lot of these cases, because of how complex the injuries were, required or were greatly aided by the use of patient-specific implants, customized implants that were provided by a company called Materialize, based in Belgium, which is actually the same company that used to provide implants for Synthes Corporation. So at some point, they recognized at the beginning of the planning, it was all ENT facial plastic surgeons and a general plastic surgeon. They recognized that a lot of these injuries would really benefit from the expertise of an oculoplastic and orbital surgeon. So a couple of the surgeons who were at Houston Methodist contacted Amina Malik, who is also a Houston Methodist and a member of Ace Hoppers. And asked her if she could maybe reach out to the community and see if anyone was available to help. So she posted this message on the chat board called DocMare for the North American Society of Academic Oral Surgeons, and asked if there was anybody who might be willing to help. So when I first read this, this was in February, right? The mission's leaving in March. And I thought, at first glance, I'm like, there's no way. I mean, I've got like patients booked out, you know, for several months, and I got to cancel clinic and ORs and everything. And then I thought about it again, and I thought to myself, you know, with everything that you've been through, with your experience in Iraq, your experience doing secondary trauma reconstruction in San Antonio and at Walter Reed, and with your particular interest in treating trauma patients, is there anything else in the world that you really should be doing besides this mission? And so I decided no, that this was something that I really had to. I really didn't have any choice. I had to participate in this mission. So 24 hours later, I contacted Peter Abdison, and I was on board. A week later, and 6 weeks later, I was in Ukraine. So these are the two missions that I participated in. The first one is in March of 23, and the second was in October 23. The first team had 13 members, so 5 surgeons, 3 ENT, facial plastics / head and neck oncology surgeons, Anthony Brissett, Joel Kane, and John Frodel. General plastic surgeon, Irina Karinets, who's in New York City and is actually a Ukrainian expat who speaks fluent Ukrainian, and then myself. Peter Adamson is the foundation director and director of the mission. A anesthesiologist, and then 4 nurses, a photographer, and a representative from Razum, Ukraine, who helped to coordinate all the activities of the team. In October, we went with 3 more members, the same mix, but 3 more nurses. And so the second time we went, again, 3 ENT facial plastic surgeons, Priya Kasarwani from Toronto, Matt Brace from Toronto, Johnny Trites from Halifax, Nova Scotia, a general plastic surgeon, Natalia Biskup, also a Ukrainian expat from Wichita, Kansas, and then myself. Paul Slavchenko, who is also Ukrainian expat, was our anesthesiologist, and then 7 nurses, Peter, again, a photographer who's actually taken the picture, and then a coordinator from Razum. So this is the location that we went to. Ivano-Frankivsk is a city in the western part of Ukraine near the Polish border. So as most of you know, most of the military action is taking place on the eastern border near Russia. So security wise, you know, there wasn't any military action taking place. So it was relatively safe. This is the hospital that we worked in, the Ivano-Frankivsk Regional Clinical Hospital. So you can't fly into Ukraine these days commercially. So we flew into Poland, Krakow the first time, and then Warsaw the second time, and then drove a bus across the border to Ivano-Frankivsk. The itinerary for both trips was identical. Thursday and Friday, we flew to Poland, met at a hotel. Saturday, we got on the bus, drove to Ivano-Frankivsk. On Sunday, we had a medical conference that was concentrated on facial trauma reconstruction for local Ukrainian surgeons. On Monday, we saw all the patients that we were planning on operating on in clinic all in one day, just to make sure that, okay, that we knew what we were dealing with, and finalize a surgical plan, get surgical consents and everything. Tuesday, Wednesday, Thursday, Friday, we operated 4 days straight. Saturday, we drove back to Poland, and then Sunday, everyone flew back home. So yeah, so here's some pictures. Here's meeting in Poland. Here's getting on the bus. This is the first medical symposium. Here's the clinic on Monday, performing surgery, getting back on the bus to Poland, and then flying back home. So this is the initial symposium that we held in the hospital itself. There's about 100, maybe 150 attendees. It went very nicely, but the second time, October, is actually, they found another venue at the local medical university. There was at least 200, 250 attendees. It was very, very well done. There were actually translators there with, so everybody had headphones that they could receive simultaneous translation during the conference. And it was like live streamed to hundreds of local Ukrainian surgeons as well. This is the ENT department that we coordinated with in Ivano-Frankivsk. These are some of the attending surgeons, and these are some of the residents. Now, it's important to point out that the graduate medical education system in Ukraine is much different from what we are used to here in the United States. So in Ukraine, when you become a doctor, you go through medical university. You don't go through undergrad and then through med school. It's 6 years, kind of like a flex program. So, so you go through undergrad and medical school all in 6 years. Then you do a residency. There's no internship. It's just a residency, and it's 2 years, regardless of what specialty you're in. It could be primary care, it could be ENT, it could be neurosurgery. It's 2 years for everybody. Okay. And then you go and you start practicing. So when you're dealing with residents here at Ukraine, they are not at the same technical level as residents that you're dealing with here in the United States. So you're basically dealing at a skill level of maybe a PGY1 or a PGY2. So the need and the desire for surgical training for these residents was tremendous. And they were there. I mean, every time you turn your head, there's a resident right next to you trying to learn from what you're doing. I also had the privilege of being able to interface with the ophthalmology department in the same hospital. They happen to be on the same floor, just across on the other side of the elevators. So this is the chief and the chair and the vice chair of the ophthalmology department. And then Angela and Mariana were the two ophthalmologists in the department who actually did the bulk of their oculoplastic surgery. But it was, basically bread and butter, bluffs and ptosis and functional strips. So they really didn't have any experience with doing socket reconstructions, orbital surgery, DCRs, and anything like that. So here's the hospital. So the top floor right here is where the ENT department is. It's just one big long hallway. At the very end is a little door here that goes into their surgical suites. And then along the hallway, there are actually inpatient bed rooms. They admitted all their patients through the entire week, and the week before and the week of the surgery. Here is a procedure room that we converted into an OR, and then here is where we actually saw our patients in clinic. So Monday, this are just some photographs from Monday, very, very chaotic. We had to get through 30 plus patients all in one day. All with trying to teach the local attendings and residents at the same time. You can see in this photograph here, there's at least 20, 25 people just within the frame of the photograph and others outside. Once we saw the patient, wrote down the surgical plan, then they would go to the next room. This is the procedure room where they would get consented and pre-op by our anesthesiologists. At the end of the day, we sat down as a team and we went through all the cases and decided on the surgical schedule. So the first time in March, this is how we did it. We had these Post-it notes and we would write down the patient's name, their information, the procedure, the surgeon on the Post-it note, and then we put it up on the wall and move things around until we got something that we thought was a workable schedule. And then we took pictures of it, and that's what we went on for the rest of the week. For October, we leapt into the 21st century and used an app called Miro, where we were able to put everything on the app. Everyone was able to have their own version of the app and see in real time. And it was much more convenient to be able to move cases around. We did a lot of that. And everyone was able to see exactly what was going on any particular day at any given moment. So this is the end of that hallway that I just showed you. This is the OR control desk. This is the door through which these two ORs, OR1 and OR2 are, OR1 is the only OR that had an overhead light. So having a headlight for myself was key. I actually happen to have an LED headlight that I can connect to a battery pack. So that was very, very important. And then OR3 was the minor room that I showed you, which was all the way on the other end of the hallway, which our original intent was just to do monitored anesthesia care cases. But our anesthesiologists were actually able to convert it into an OR where we could actually put people to sleep and do general surgery. This shows there was actually some people from Storts who came in and live streamed surgeries to local surgeons throughout the week. So this just, and these are some microphones that they gave to certain surgeons to wear so that we can narrate the surgeries as we're going along. So just a few action shots. You can see myself here, Johnny Treitz, Tanya Pavlichuk, who's a oral maxillofacial surgeon from Lviv, both of us wearing these microphones as they're live streaming the surgery. This is Matt Brace and Talia Kamashko, who is the main coordinator for the mission on the Ukraine side, performing a paramedian forehead flap for nasal reconstruction. This picture kind of demonstrates the kind of teaching that went on. This is a cross-face facial nerve graft for a facial palsy patient. And so you have the team up here working on the face, and then you have another team harvesting the sural nerve graft for the facial nerve. And there's at least 12, 14, 15 patients, people in the frame of this picture, all just trying to get as much learning as they can. The Materialize team from Belgium, who created our patient-specific implants, very, very important. You can see right here them actually showing us during surgery the scans and the implants and showing us anatomic landmarks to give us the best chance to get these implants positioned the best way possible. So we did 60 cases over the two missions. Both missions had exactly 30 patients. And out of those 60 patients, 35 were cases that I was involved in that required oculoplastic and orbital surgery. So this is the breakdown of the cases that I did: a bunch of fractures, 14 blowouts, the ZMCs, the transnasal wiring, a lot of socket reconstructions, 12 enucleations, 15 dermis fat grafts, a bunch of heart palate and bulk of mucous membrane grafts, a lot of lid procedures, as you would imagine, G-Hughes flaps reconstructions, 11 skin grafts, a bunch of lid malposition repairs, lateral canthotomies, wedge resections, 3 lid weight implantations for facial nerve palsies. And then as far as the face goes, several mid-face lifts, a cervicofacial flap, brow plasties, and 2 Z-plasties. And then as far as lacrimal goes, 3 DCRs. I think 2 of them were endoscopic and 1 of them was external, and then 1 CDCR where I placed a Jones tube. I only had like 2 Jones tubes with me, and as luck would have it, the exact size that patient needed was the size that I had. So, so total, if you add up all the procedures, 107 billable procedures. So these are the patients that I operated on. These are the 15 patients from the first mission, and these are the 20 patients from the second mission. So I'm just going to show you some examples of some of the patients that I operated on. This is a patient from the March mission who completely lost his left eye. His eyelids had severe, obvious deformity of his periocular region and face. When I looked at this guy, I told him, listen, I don't know what's behind the skin here. I don't know what I can do for you. I can open things up and I can try to reconstruct a socket so that you can wear a prosthesis, but I have no idea if there's any chance that it's going to succeed. He said, well, just give it a try. So I basically made an incision where I thought palpebral fissure belonged, explored the orbit. There was not much there besides fat, maybe a tiny little bit of conjunctiva here, possibly. So what I did was I placed a dermis fat graft in the socket and then 2 buccal mucous membrane grafts to try to give him to try to reconstruct the palpebral conjunctiva of the upper and lower lids and give him some semblance of fornices. This is him pre and post-op. Unfortunately, this reconstruction failed. Several months later, pretty much everything just kind of shriveled up. He was not able to wear an ocular prosthesis, but it was an important learning experience for me. And this emphasizes the importance of vascular supply. This guy had no vascular supply whatsoever. And so if I were to do this again, if I was willing, it would probably require some sort of flaps, maybe a paramedian forehead flap to reconstruct the lids, maybe a temporalis muscle flap, bring it in the orbit to provide some vascular supply, maybe a nasal septal flap that you can bring in through a medial canthus incision. But this is just an example of sometimes things don't work when you want them to. This patient lost his right eye, had an evisceration, had some bony defects as well. He had a defect of the supralateral orbital rim and an orbital floor defect that they created a patient-specific implant for. We decided not to use this, not to have a PSI made. We just used MedPore sheet to reconstruct the supralateral rim. And that part went just fine. But when I got into his orbit to put a dermis fat graft in or whatever, this is what I found. So here's the scleral remnant. And then inside you can clearly see uveal tissue. Okay. And so it turned out, I did about 11 of these and every single one of them looked the same. They had this shriveled up scleral shell and then uvea inside of it. So the first time I saw this, I'm like, I can't leave this in here. You know, what if he develops sympathetic ophthalmia? So I just did a completion enucleation, put a dermis fat graft, and then called it a day. This is a patient I also treated. I treated on both missions. So the first time he came in, he looked like this in March. I tried it. He had already actually been operated on already by the September team from the AFPS. They had done some orbital fracture repair with a PSI, and he actually looked pretty darn good. I told him, I'm not sure how much better I can make you look. And this is him afterwards. Honestly, really not looking that much better. But the reason he came back is because he developed this exposure of his orbital implant that had been placed the year prior by the AFPS team. And he had this fistula because there's holes in the implant. So he was blowing air from his maxillary sinus into his socket. So what we ended up doing to repair this fistula was a pericranial flap. So we opened up this brow scar that he already had. We developed a pericranial flap here. You can see it in situ. And then we reflected down into the socket and used it to cover this exposed implant here. So you can see it in place here. We haven't sutured it yet, but we used it to, this was also not just to reconstruct repair the fistula, but also to provide a little bit more fornix for his inferior fornix and his medial fornix, which as you can see here was pretty contracted. So I don't have any post-op pictures from him, but he ended up doing well, had no recurrence of this fistula. This is another patient that I treated on both missions. This is from the March mission. Obviously lost his left eye and had severe comminuted fractures of his zygomatically-maxillary and buttresses. So you can see he does have some upper lid here. Most of his lower lid's gone. He does have some conjunctiva here. So in March, what we concentrated on was reconstructing his face mostly. So we have these PSIs made by Materialize, and this shows repositioning of these bone fragments. To be totally frank with you, the thought that we would be able to reposition all these fragments in a perfectly on time location, that's a pipe dream. Okay. But we did the best we could. We have to have something to aim for. And so this is what he looked like post-operatively. And honestly, it doesn't look all that bad. His orbit's looking pretty good. Unfortunately, his zygomatic arch, there's still a pretty big gap in it. But from an orbital standpoint, I was pretty darn pleased with this. However, when he came back, and also I did a Hughes flap reconstruction to reconstruct the lower lid defect. So this is him, multi-disc skin graft. And then afterwards, about a month later, I gave the local ophthalmologist instructions on how to do the stage 2 takedown of the Hughes flap. Actually, as soon as I got back home, I took a video of a Hughes flap reconstruction that I did and then sent it to them, and they did the takedown, and he did really nicely. But he came back in October looking like this. So he is able to wear a prosthesis. His cheek looks pretty good, but he still has some pretty significant orbital dystopia. His lid, he's got a pyogenic granuloma here, he's got lateral canthal dystopia, and he has pretty significant enophthalmos as well, okay? And the inferior fornix was pretty contracted, so there was very, very little fornix. So what we proceeded to do was place a dermis fat graft in his socket, release the scar tissue, made an incision all the way across underneath here to release the anterior lamella, release the posterior lamellar defect. The problem is that when you release both anterior and posterior lamellar defects, you have a full thickness defect, big hole in the lower lid. You can't put a graft over that. So what I did was a rotational flap from the lateral canthus and cheek, rotated that in, took this piece right here, this piece of skin that I had to remove anyway because of the standing cutaneous deformity, and used that as a skin graft for right here, where he still had posterior lamellar intact. So this is what he looked like at the end of surgery. Here's the rotational flap. Here's the skin graft, bulbomucous membrane graft for the posterior lamella to recreate his inferior fornix, and again, the dermis fat graft. And so this is his result. He's very happy, and I'm very happy too with this. It took 3 stages. So first the facial fracture, Hughes flap reconstruction, then a stage 2 Hughes flap takedown. And then this guy also had that partial evisceration. So I did a completion enucleation, dermis fat graft, bulbomucous membrane, both into skin graft right here, and a rotational flap and a lateral canthopexy. And so he's got a pretty decent looking socket. Here's a patient with a ZMC fracture, significantly displaced. You can see his malar eminence is way down and out here. Also lost his eye. So here's the PSI designed by Materialize, 2 PSIs, one for the orbital floor and one for this missing bone of the superlateral orbital rim. So we repositioned, we had to do several osteotomies to free up this zygomatic segment, got that repositioned, put this PSI into place, put the other PSI along the orbital floor, completion enucleation. Here's his post-op scan. And here he is with a very nice result, able to wear a prosthesis. Cheek looks much better. We did do a full thickness graft to the upper lid, which contracted quite a bit because of the poor blood supply. But I think this is a pretty darn good result. I am going to skip to this will be the last case here. So this is a patient who obviously has severe trauma and bony loss of his cheek and maxilla. He lost his eye, and he has severe trauma to the lids. Now, you may look at this and say, well, this looks a lot like that first guy that you treated from the March mission. Why do you think this is any different? Well, the key here is that right here, there's a little bit of a palpebral fissure right here and right here. So this is actually ankyloblepharon. And so my hope was, if I release this, maybe I'm going to find some socket in there, some conjunctiva, some normal, something of normal lid tissues. So we designed a PSI, 2 PSIs, one for the anterior maxilla, one for the orbital floor and the inferior orbital rim. Opened up the scar that he had in his cheek, put the PSIs into place, did a cervicofacial flap to reconstruct his anterior lamellar defect. I did some revision of his eyelids, and this is him immediately post-op. This is post-op CT scan, and this is his a later post-op result. So he's got a socket, he's got a dermis fat graft. Yes, there's some orbital dystopia, lateral canthal dystopia. He may need some revision here, but he's got a socket. He should be able to wear a prosthesis. He's got a conformer here, and his cheek scar obviously looks much better. He's got very good projection. So I was very happy with this result as well. I'm gonna skip over this last one for the sake of time. We are kind of at our end. Yeah,
Last case?
yeah, you want it? Okay, all right. This is the
This is
last. case.
fascinating.
So here's a patient, again, severe bony loss of his facial buttresses. This is a sighted eye, actually. So he kept his eye. He's got this severe scar and deformity of his cheek and this large festoon due to the loss of lymphatic drainage. So 3 PSIs. This is the most complicated PSI case that we had. So 1 PSI for the inferior rim and the orbital floor, another PSI for the anterior maxilla, and a 3rd PSI for the zygoma. And the thing that the engineers at Materialize did, which they had not done before, was they made little tabs. So here's a tab in this PSI that fit into this little hole into the maxillary PSI. And then the maxillary PSI had another tab here that was designed for this zygomatic PSI. So they were interlocking PSIs. This was a hell of a case, but very happy with how things eventually went. We got the PSIs, I think, reasonably positioned. And this is him, his late post-op. Unfortunately, we're not able to get a post-op CT scan on him. Did a festoon excision, which looks better. There's still a little bit of a festoon there. He's got some lateral canthal dystopia, but I think this is a good start for this patient. So obviously teamwork, very, very, very critical. Both missions we had on the very last day on Friday night, we had a celebratory dinner. We invited everybody who was involved in the mission to come and help us celebrate. But I put this picture in here just to highlight how many different teams of people were critical. These are the surgeons from Canada and the US. Here are the ophthalmologists that I worked with, the ENTs here, Natalia Kamashko, who was the main point person in Ukraine, Peter Avison, who was our mission leader, translators, absolutely critical to the success of the mission. We had an army of 8 translators, nurses, and the Materialize team. This is a true team effort. And I think the mission went as smoothly as you could possibly. Of course, there are hiccups along the way, but we dealt with each situation. And I think at the end of the day, we were able to provide some pretty darn good care and education for the local Ukrainian surgeons. So the last day, a Saturday, we did our last rounds with the patients, said goodbye, drove back to Poland. This is our after action report that we did on the bus on our way back to Poland. And then we all headed back home. So a lot of things that were involved, you know, as far as the keys to success for the mission, obviously you have to pick the right people to participate. Planning was absolutely critical, communication between all members of the team, teamwork, absolutely essential, leadership from Peter Adamson. The second time he actually asked me to be the surgical team leader. We also had a nurse team leader. And so we all had to kind of work together to make sure that everything went as smoothly as possible. Flexibility, obviously, when you're in a country that doesn't have the same kind of resources that we have here, you have to adapt to situations where you don't have the things that you are used to having here in the United States. Developing relationships, going back a second time for me was just absolutely just delightful to be able to work with the same Ukrainian surgeons that I had worked with the first time and to continue those relationships. And I do plan on going back this October again to the same location. So just to wrap up, before I went on the first mission, my partner, Shruti Akella, who had just come on board at Ohio State, gave me this as a gift. And for those who aren't familiar with the work of Sir Harold Gillies, he is considered the father of modern plastic surgery. And he got his experience through treating facial wounds in World War I. So if you have any interest in the history of facial plastic surgery, pick this book up by all means. When I started my career in 1994 at Burke Army Medical Center, this was
this is the old Brook Army Medical Center in San Antonio. It's no longer used as a hospital, but this inscription is at the top of the portico every time I walked into the hospital every morning. And this kind of became my guiding light through my career as a military surgeon. Whatever your feelings are about the military and about wars, and my personal feelings have evolved a lot over the years. These patients, these soldiers and civilians in Ukraine that are defending their country against Russian aggression, they need help. And it was an absolute privilege for me to be able to go over there and provide the little bit of help that I was able to. And more importantly, pass on some of my knowledge and skills to some of the local Ukrainians so they can continue to provide care for the brave men and women who are defending their country. So this is a picture from the New York Times, just kind of, to me, represents the Ukrainian soldiers who have been defending their country for almost the past 2 years. Thank you very much.
Thank you so much. Thank you for serving our country. Thank you for serving the international community. Thank you for sharing that experience with us today. It was powerful.
You're welcome. Thank you.
Great. And I'd just like to present you with this special plaque to commemorate your visiting professorship here today at the Flaum Institute. Yeah, thank you.
Are there any questions? Nobody? Please.
Thank you so much. That was an incredible talk. Could you just talk a little bit about the patient selection process? I mean, I'm sure the need was overwhelming, and how did you determine which cases to take on?
Yeah, I mean, that was a very difficult thing because the local department in Ivano-Frankivsk, they must have screened several hundred patients. We got it down to like 60-ish that we actually reviewed, and then we had to whittle that down to 30. So we had to kind of weigh, we had to consider, okay, who are the patients that we can help the most with the limited resources that we have, with the limited amount of time that we have, and with the skill set of the particular set of surgeons that we have. So yeah, it was a process, and we met, you know, like every week for several months over Zoom to determine who we were going to operate on. Any other questions? Yes.
I wanted to see if you could speak on just like the interval change that you noticed with the residents and the trainees from the mission trip in March and then the mission trip later.
Yeah, definitely. You could tell, you could see a difference. One of the things, I think one of the procedures that they had never done in that department when we arrived in March was paramedian forehead flaps. And we did several of those, and we did even more of, like twice as many the second time we went. So not only did they get to learn how to do paramedian forehead flaps, which is a pretty basic procedure for most EMTs here in the States, but they had never done them. And then they got to learn how to do the stage 2 takedowns of the flaps. They got to see their final results. We may have done 1 or 2 revisions when we went back in October. For myself, I was able to teach the local ophthalmologists how to do dermis vac grafts, both the skin grafts, you know, things like that, things that they weren't familiar with. So, and a lot of these patients that I treated were like pretty simple, you know, this patient's an ophthalmologist after they had her eye removed. All they need is a dermis vac graft. And so now I don't have to go back and treat those patients anymore. They can do it themselves. Yes.
How would you, what was the method of communication with the local ophthalmologist after you left regarding post-op issues for the patients that were?
WhatsApp. Yeah, literally.
WhatsApp.
We were all on a WhatsApp group, and they would, you know, send photos, ask questions, everything. We did a couple also Zoom calls We did like at 1 week, we did a Zoom call, and then a month we did a Zoom call. Might have done another one at like 3 months. Just to kind of run through all the patients, make sure we had no questions, you know. Yeah, so communication is critical. But WhatsApp is a great app.
You could maybe share some tips on how to optimize multidisciplinary surgery whenever you've got multiple surgeons that are going to be operating in a very close field.
Yeah.
Any tricks that you've picked up to allow for optimal success?
You know, every situation is different. You know, you're gonna have a different, usually a different group of surgeons in the room. You're gonna have a different patient who has different procedures that need to be performed. So you have to kind of get to know the people on your team and what they're capable of, what they're comfortable with, what they're not comfortable with. And yeah, that was another one of the big challenges was when we put together this big OR schedule with the patients on it, who's gonna do which case? Yeah, so, hammering out, you know. But, you know, when you're in there, you kind of have to check your ego at the door. And, you know, because you have to recognize this, you know, as much experience that I have, you know, there are things that I don't know how to do or don't do as well as some other surgeons on the team. Hey, you know, why don't you do this certification facial flap? You know, I've done some, but you've probably done 5, 10 times as many as I have. So
What were some of the, I know you spoke that there were some hiccups along the way, and I was wondering if you could speak a little bit about what some of those were relating to either, you know, setting up the eventual OR for, or whatever it was. I was just wondering if you could speak a little bit about any of those.
Yeah.
And kind of how you as a member of that surgical team kind of overcame it or worked with your other team members to get there, just in that kind of circumstance.
I think probably one of the main issues that we had during the first mission was sterilization measurements. We had a sterilizer that we had somebody had purchased for us specifically for the mission, but it wasn't large enough to fit most of the trays that, you know, the instrument trays. So, and then the hospital, of course, had their own sterilizers, but the people who ran those sterilizers, they didn't work past whatever 4 o'clock in the afternoon. So, so that was one of the main issues we ran into in the first mission. We had to kind of figure out ways to break down sets or use other sets that, you know, to just do what we had to do. And then the second time around, we came back, we're like, okay, we're gonna make sure that this thing is taken care of, and it went much smoother the second time. But there's always little things, you know, like one time they couldn't find the lid weight that I wanted to use for a particular case, you know, so I don't even remember what we did, but I had to figure out another solution to get a lid weight in that patient. Yes, ma'am.
I'm curious about like the partial eviscerations and the lack of SO that you were seeing in those cases. That the Ukrainian surgeons talk about, like why they potentially leave uveal tissue? Was that ever discussed?
Yeah, unfortunately, we never had the opportunity to talk to the actual surgeons on the front lines who were doing those procedures. They clearly weren't ophthalmologists. So I don't know, they're probably just general surgeons or whatever, or I don't know. But because I talked to the local ophthalmologist and said, hey, did you know that this was happening? They're like, no, we had no idea. So, and I honestly don't know who the best people to talk to are, but at least the local ophthalmologists are aware of the issue, and maybe they can figure out how to address it.